Dear student, Pemphigus vulgaris is very, very important for your exam. You can get a long case. You must be doing Nikolsky sign. You must be aware of this sign, and this sign is very, very important. They can ask you what is Nikolsky sign, how it is elicited, okay, what are the various types of Nikolsky sign. You know what is Nikolsky sign? Nikolsky sign when we are putting a tangential pressure or a shearing stress or shearing pressure, shearing tangential pressure when we are putting. So what will happen? There will be extension of the blister. Okay. And when you're doing in the margin, okay, the normal appearing, the margin, we are not doing on the existing erythema, or when you're not doing on the lesion, it is called as marginal Nikolsky when you're doing on the margin within 1 centimeter. Okay. And when you are doing the same Nikolsky sign far away in a normal appearing skin, very important to know is that even if there is a erythema, it is taken as an activity of Pemphigus vulgaris. So make sure you are doing on a totally normal appearing skin. Try to do on a bony prominence. Okay. So when you are doing on the lesion, okay, you are supposed to put a lateral, okay, lateral shearing pressure. Okay, that is called tangential pressure. And when we are doing other areas, you can even rub it. When you rub it, when epithelial, there is a detachment is there. When epithelial comes out, epithelial layer comes out, it is taken as a positive Nikolsky. So what happens when you take out the epithelial layer, or when the, when the epithelial layer get peeled off? So you get an eroded base. If the eroded base is, moist, glistening, okay, it is taken as, it is called as wet Nikolsky sign. And when the base is dry, it is dry, if the eroded area is having a dry base, okay, it is called as dry Nikolsky. See, dry Nikolsky signifies that the disease is, getting better. There is a re-epithelialization, okay, or it can be a case of very superficial blistering in the case of Pemphigus foliaceus. So you can get dry Nikolsky in Pemphigus foliaceus, or you can get dry Nikolsky when there is a re-epithelialization, or it is getting better, or it is getting healing lesion. Okay, it is healing beneath your, okay, beneath the blisteral surface. Okay, so you have to understand wet. You understood what is dry Nikolsky. What is wet Nikolsky? Wet Nikolsky is actually the glistening moist area. When you get the erosion is the base is, that tells you the disease is very, very active. Okay, we will be seeing a lot of slides. I am not, just till now I have not moved the slide, so I'm just giving you an overview about the disease. So Pemphigus vulgaris, it's a superficial blistering disorder. Superficial, I mean to say suprabasal, or it can be glandular layer if it is Pemphigus foliation, but it is not subdermal, subepidermal. It is supraepidermal. Okay, so it is happening in basal. It is happening in suprabasal layer in the case of your Pemphigus vulgaris, or if the blistering, or if there is a clefting is happening, if the split is happening in glandular layer, it is a case of Pemphigus foliation. So Pemphigus, overall, this is a group of diseases. So Pemphigus vulgaris is one out of them. Okay, so we have to understand. So Pemphix means bubble in, okay, bubble in Greek language. That is, Pemphix means bubble. So that's why, because it's a blistering disorder, this word has come from Pemphix. That's a bubble. Okay, so you have already understood the anatomy of desmosome. Okay, I have already shown you DJ. What is DJ? You can attend my anatomy class. You can, watch the video, and you will understand what are the various parts of desmosome. So you will understand this session easily. Okay, so in order to understand Pemphigus vulgaris, you should have a sound knowledge of your anatomy of desmosome. Okay, you should know what is keratin intermediate filaments, how are they maintaining the shape of the cell, and they are attached to the inner plaque of the desmosome. Okay, and how desmosome is present in between the two cells. Okay, and you must be knowing about the cadherins. Okay, the cadherins are Desmoglein, Desmoglein. They are the transmembrane cadherins which are, holding the outer part. They are the part which is in between the cells. It is, and passing through the transmembrane and going the outer plaque of the desmosome, and there is an inner plaque of the desmosome. I will be showing you certain photographs also, but this is what we have already covered. So we are going to discuss this autoimmune disorder. Okay, so I'm starting the slide 1. First of all, you should know the anatomy of the, how to, what are the words you are going to, the terms you are going to describe, because you have to describe about mucosal pemphigus. See, pemphigus vulgaris affect almost 50 to 70% of the cases. They will be having a mucosal involvement. That is very, very important. And the history even start 5 to 6 months before. So before getting skin lesions, you will get oral lesions. So you should know how to tell where are the lesion. Okay. So you can see here, this is buccal, this is a buccal mucosa. Buccal mucosa, that is inner side of the, that is a buccal mucosa. You should know what do you mean by gingiva. This is upper gingiva. What is upper lip? So if they are present inner side in the mucosa of the lip, you can say labial mucosa, the upper labial mucosa, or lower labial mucosa lesions are present, or in the buccal mucosa lesions are present. Whether the lesions are present on the soft palate, whether they are present in the hard palate, whether they are present in the pharynx. This is uvula. Okay, there are tonsils here. This is tongue, and just below that there is a floor of the mouth. Sometimes lesions are present on the floor. So what type of lesions you get in the Pemphigus vulgaris? Pemphigus vulgaris, you can get erosion, that is the denudation of the epithelial layer. So you can get erosion, you can get ulceration, you can get, ginger, there can be erosions. Even you can get even collapsed vesicles. You can get even vesicles also, and they look, actually the vesicle, when they collapse, actually they form like a whitish type of layer, whitish type of structure they look like. But if you see properly, they are actually nothing but the collapsed vesicle. So you can get vesicle, or you can get collapsed vesicle, or you can get denudation of the, okay, you can get erosion, erosive gingivitis you can get. Okay, you can even these are the lesions you have to see. Even you have to look outside of the lips also. There can be, lip lesions on the erosions or the ulcerations over the lips also, not only in the labial mucosa or directly on the lips also. So the involvement of mucosa is very, very important, and we'll be discussing various other mucosas are also involved, like conjunctival mucosa, right? So even esophagus mucosa can be involved, okay? Because it can cause the complete layer of the esophagus of the epithelial, this mucosal layer of epithelial sometimes can wash slough away, okay? Can actually can slough away even the complete mucosal layer of the esophagus, because it is rich in desmoglein 3. So we have to know that pemphigus is a disease where it target the, the auto antibodies are targeting the cadherins. What were cadherins? We have already discussed. They are calcium dependent, these are calcium dependent molecules which are helping in adhesions. So the cadherins which are present in desmosomes are desmocollins and desmoglein. So basically in Pemphigus vulgaris, there is an attack on desmoglein. So majority, see, the antibodies are against the desmoglein 1 or 3. And we know in the mucosa mainly the desmoglein 3 are present. So we will be seeing what is desmoglein compensation theory. Why? Because if it is only oral, or you can say mucosal pemphigus vulgaris, when it's involving the oral cavity or mucosal cavity. So especially the antibodies are against the desmoglein 3. As I mentioned, mucosal involvement is much before the skin involvement. So if they start getting skin lesion, that means they're getting antibodies against the desmoglein 1. Actually, desmoglein 1, in Pemphigus foliaceus, the antibodies are against only desmoglein 1. In Pemphigus vulgaris, there will be antibodies against either can be desmoglein 3 or desmoglein 1. So why in Pemphigus foliaceus we are getting only superficial lesion? I'll be showing a desmoglein compensation theory, because the desmoglein 1, if their antibodies are only desmoglein 1, the desmoglein 3 which is present in the lower layer will compensate for the loss of the desmoglein 1. So we are getting only superficial blistering in the granular layer. But if this mucosa we are having only desmoglein 3. So it is whole and soul dependent upon desmoglein 3. So if there are antibodies against desmoglein 3, nothing is going to compensate. So there will be erosive gingivitis or erosions or ulceration. You can get vesicle. Okay. The lesions in the pemphigus, the pathognomic lesion is a fluid-filled lesion, that is the bulla, and the bulla which is basically flaccid bulla. So this flaccid word you have to use every time. Initially it may look tense or maybe a tense, but actually the pathognomic is a flaccid bulla which easily rupture and leaves behind painful erosion. That history you have to even write in the patient language. That patient, according to the patient, lesions comes as the fluid filled lesions comes and they easily rupture and they leave behind painful erosion. This type of sentences you have to use to tell the story of the patient about the HOPC, history of presenting complaint. So you can see here upper lip, you can see lower lip. You have to use this word like gingiva, upper gingiva, lower gingiva, and there is an area behind the molar. Molar, this is called as retromolar area, and this is a retromolar trigone. Here is a retromolar area. It is retromolar trigone. They are okay, and this is a soft palate. Soft palate is just okay. This is a hard palate. So you should know where are the lesions, whether they are the hard palate, soft palate. You should be good in oral anatomy also. So please go and read again the books, or you can see the photographs, which is showing the real for pictures of oral cavity. But this is enough actually. And even you know about these words, soft palate, hard palate, upper gingiva, you that examiner can imagine when you are telling the history, because history telling is like a storytelling. Okay, and when you're doing a pair depiction, they should imagine where the lesions are. Okay, so you should know about this buccal mucosa. So what is happening, as I have already mentioned, that Pemphigus vulgaris is an autoimmune disease. There are antibodies against the cadherins component of the desmosome. So mainly Desmoglein 1 and Desmoglein 3, or the antibodies are produced. And but the what is the meaning of acantholysis? Acantholysis is a loss of cohesion. Loss of cohesion of the keratinocyte is acantholysis because of disorganization, or because of their disorganization or separation or destruction of the disorganization of the desmosome. So when there is a destruction or disorganization of the desmosome leading to the detachment of the keratinocyte or loss of cohesion, that is called as acantholysis. So what happened actually when they looked by the immune electron microscopy, they were very shocked that even desmosomes were even intact till the late phase of the complete acantholysis. So they wanted to understand whether any other antibodies are there, because in when you do the ELISA of the blood, you are when you are doing the serum, so you are getting Desmoglein 3 and Desmoglein 1, and this is available. These kits are available. These checkups are available. You can send ELISA. ELISA is a very, very important test to know the prognosis, whether the patient is in remission or not. Okay, because when these desmogleins are completely absent, the patient are in going for remission and all, and there even quantification we can do. So Desmoglein 3 and Desmoglein 1 are there in the ELISA, that is actually supporting that we are in the right track. But they found there's something else is happening. So then they discovered there are peripheral myelin protein. There are antibodies against the peripheral myelin protein, or cholinesterase. This acetylcholine receptor. So they found that there are antibodies against the acetylcholine receptor, or peripheral myelin protein, which were binding their targets on the keratinocyte membrane. So two things were happening. The structure of the keratinocyte were changing, and actually what was happening, the two things were happening. One is the increased phosphorylation of the adhesion molecules. So when this phosphorylation was increased, so there was a dissociation of the adhesion molecules and the tonofilament. Tonofilament means the cadine intermediate filament. See, the whole cell is having a lot of cadine intermediate filament, which is maintaining the shape of the cell, which is maintaining the position of the nucleus, and cadine intermediate filament on the both sides are attached to the inner desmosomal plaque also. So when the tonofilament will collapse, or you can say the same thing, cadine intermediate filaments are collapsing, so cytoskeleton of the cell is collapsing. So that is leading to the shrinkage of the cell. That is, the keratinocyte will shrink. So what will happen when cell will collapse? So desmosomes are in between. So what will happen? That their desmosome will get dissociated, or there will be dissociation of the desmosome, or disorganization of desmosome also. So finally what will happen? This desmosome will be sloughed away. Sloughing of the desmosome will be there. So when the desmosome are sloughed away, so what will happen? This is called as acantholysis. Okay. So when these desmosomes are sloughed away, the desmosomal cadherins will come under the immune surveillance. And when they come under the immune surveillance, these are new, or these antibodies will be produced against even the cadherins of the desmosome. So that this theory tells that this is a secondary process. The antibodies against the desmosomal cadherins is a secondary process when they are exposed. When something is getting sloughed away, our immune system will recognize something is happening bad. So it will come under immune surveillance, and they will, this is because of the epitope spreading. This will, desmosomes will be coming under, immune surveillance, and the cadherins will be targeted by the autoantibodies, and finally you will start getting desmoglein, and it will become a vicious cycle. It will become a vicious cycle. See, when antibodies will bind the cadherins, what will happen? There will be hysteric hindrance will be there. Hysteric hindrance will be there. They cannot unite properly. There will be autoantibodies in between. So it will cause hysteric hindrance. So they cannot do their job properly. So that there will be dissociation in the adhesion. So hysteric hindrance is one theory. One theory I've already told you this. This is because of the shrinkage of the keratinocyte. Why there is a shrinkage of keratinocyte? It is because of the anti-peripheral myelin protein and anti-acetylcholine receptor antibodies are there, which are targeting the keratinocyte membrane. And when they are targeted, there's some physiological control. Normally there is some physiological control which maintain the polygonal shape. When the polygonal shape is disturbed, the keratinocyte intermediate filament will go for clumping. And when they will go, why they will go for clumping? Because there is a phosphorylation of the adhesion molecules. So everything is started by these antibodies, not by the desmoglein antibody. So finally, once this desmosomes are sloughed away, and there will be autoimmune response elicited to the desmosomal antigen. And anti-desmoglein antibodies find to their target on the keratinocyte membrane, and finally, it will formation of a new intercellular junction will be prevented. As I told, it will cause steric hindrance. So steric hindrance is one theory, okay. And one theory I already showed you that these are working in combination actually. So one is because of the cell shrinking theory. So basal cell are getting they are shrinking. Next thing is that because of this EGFR MAP kinase pathway, that is a cell signaling pathway, very very important pathway. And when this pathway is activated, there is a elevation of the intracellular calcium also. And this calcium and this EGFR MAP pathway, when they are activated, they will activate the caspases. Caspases are leading to apoptosis. They will cause the plant cell death. They will cause the programmed cell death. They initiate it. So this is one theory that is called as apoptosis. So when this acantholysis and apoptosis and the shrinking of the cell together, if you call this, what is called as apoptolysis. So apoptolysis is a concept which is joining all the three things: acantholysis and your cell shrinking, basal cell shrinking, and your apoptosis. So this is called as apoptolysis. So basically, in short, you can say apoptosis of the acantholytic cell. But obviously, acantholysis is already happened, and then apoptosis and cells have shrunken. So all these three things together are there in apoptolysis. So this is called as theory of apoptolysis. So there is a theory of steric hindrance. They will go and bind their cadherins. So what will happen? They will not be be getting a proper place to join. They will not be. This will cause disorganization. This will call disorganization. This will call dissociation. So disorganization, dissociation of the desmosomal cadherin, leading to the sloughing of the desmosome, and finally causing loss of coherence of the cells keratinocyte. It is called as acantholysis. We will be discussing acantholysis as a separate, because there is primary acantholysis, secondary acantholysis. We have to discuss separately. So that's why there is a cleft formation. There is a cleft formation. And I told you in mucocutaneous pemphigus, there will be antibodies against both desmoglein 1 also, desmoglein 3 also. But if it is a mucosal only oral pemphigus, then it will be against only desmoglein 3. The shape of the 3 is like a lips. So I just remember 3 is like a lips. So 3 is for the mucosa. And number one is so pemphigus foliaceus, only number 1 is involved. Pemphigus vulgaris, both can be involved. And always take a history. Sometimes you don't get cutaneous lesion at all. Sometimes they are having even conjunctival erosion, conjunctival ulcerations can be there. Your nasal mucosa can be involved. Okay, so that is very very important. And you can even get even esophagitis, or you can get ulceration over the genitalia. So very very important. Sometimes you don't get cutaneous, so that history has to be elicited. Okay, so this you have already understood. So now they have understood the initial process is not the desmosomal cadherin antibodies. It is something else. What is that? That is the antibodies to what are the antibodies? Anti-PERP and anti-AChR. Okay, which is leading to the physiological control of the polygonal shape of the cell is lost. And once the shape is uncontrolled, it is destroyed. it will lead to phosphorylation or increased phosphorylation adhesion molecule, which I already told you, which will lead to the dissociation adhesion molecule and the collapse of the tonal filament. And one pathway was the EGFR MAPK pathway and cell signaling pathway and increase in calcium level, which was activating the caspase. So we have already explained everything in this slide. So I'm going to the next slide. So you can see here there are anti-desmoglein 3. See, this is a cell membrane. This is a cell membrane. This is a cell membrane. These are transmembrane cadherin. This is called a desmoglein. Okay, and you can see here there is a outer plaque which is having placoglobin. Placoglobin is important when we are dealing with a paraneoplastic pemphigus. Okay, these are keratin intermediate filament. These are keratin intermediate filament. These are keratin intermediate filament. So you can see very nicely. This is actually a desmoplakin DP. So desmoplakin is joining the keratin intermediate filament to the outer plaque of the desmosome. Okay, this desmoplakin is considered as inner plaque. This is considered as outer plaque. These are keratin intermediate filament, and these are transmembrane cadherin. This cadherin, desmoglein and desmocollin are transmembrane because they start from the outer plaque and they go outside and then they do the junction. They will do the shunting. Have you seen the train compartment are shunted to each other? They will be doing shunting from the other cadherins from the other cell. Okay, so you know this keratin intermediate filaments are attached here. So even if this keratin intermediate filament will collapse, so everything will be destroyed. Even this desmosome will not have a support to where to join. So they will also slough away. Once they slough away, there is a problem. So now this is MAPK38 pathway, which has come up as an important pathway, which I told you. Binding of autoantibodies to the desmoglein induce an alteration of cellular signaling component also. So now they are producing drugs which are targeting P38 MAPK. So P38 MAPK protein kinase, including internalization of DSG3. The autoantibodies binding reduce the RHOA activity, the P38 MAPK dependent manner, which impact the reorganization of actin cytoskeleton, because this pathway is finally leading problem in the organization of actin cytoskeleton. Okay, so and drive further loss of desmosomal integrity. So this is a new theory coming up. I already told you about there is a steric hindrance. So interaction of the pathogenic antibodies. These autoantibodies are actually against the amino terminal of the desmosomal protein. So please remember, sometimes they ask you whether it is a carboxy or it is an amino terminal. So antibodies are against the amino terminal, leading to steric hindrance of trans. So one is P38 MAPK pathway, another is just a steric hindrance, because when these autoantibodies are binding to desmoglein, they will lead to alteration in cell signaling pathway, and which is the cell signaling pathway? P38 MAPK pathway. And P38 MAPK pathway is very, very important pathway to maintain the actin cytoskeleton. So an actin cytoskeleton is finally maintaining the integrity of desmosome. So when actin cytoskeleton pathway is affected because P38 MAPK pathway is affected because of binding, so finally in turn it will lead to the loss of integrity of desmosome. Caspase signaling pathway is activated by the signal induced by the binding of autoantibodies to desmoglein by the fast ligand receptor pathway, including the pro-apoptotic caspase signaling. We already seen this anti-cholinesterase, acetylcholine receptor antibodies are there, which will cause disassembly of the various adhesion molecule, leading to acantholysis. Okay, because they are impacting the protease inhibitor. So you have already seen this. We have seen this slide now. The earlier slide we have already seen. So okay, now this is desmoglein compensation theory. What is happening in Pemphigus foliaceus? You can see that normally in a skin, desmoglein 1 is there more in the upper layer, but it is there throughout the skin. Okay, and the desmoglein 3, if you see, desmoglein 3 is there more in the lower layers, but it is there little bit upper layer also. So when Pemphigus foliaceus, there is only antibodies against the desmoglein 1. So what happened? Even desmoglein 1 is lost. The desmoglein 3 will take care of the lost desmoglein 1. So the disease is not that superficial. Okay. And so the disease is very superficial. It's not that bad. Another thing is that we know in the mucosa it is mainly desmoglein 3, so there is no lesion in the mucosa. So the upper layers upper layer are not that compensated. That's why the blister is in the upper layer. In the lower layer, Desmoglein 3 will take care. So that's why the blistering in the Pemphigus foliaceus is the upper layer. Okay, understood? If you see the mucosal Pemphigus vulgaris, there are antibodies against the Desmoglein 3. And we know there is no Desmoglein 1 to compensate with the loss of Desmoglein 3. So there will be severe ulceration, okay, severe blistering, severe, the skin will become fragile, it will be lost, okay, there will be denudation or ulceration, okay, that is very important. Then mucocutaneous, when the antibodies are against the Desmoglein 1 also, Desmoglein 3 also, so they will be having oral ulceration. And now you know that because Desmoglein, when only Desmoglein 1 was affected, Desmoglein 3 could have taken the place, but now here they are both are affected, so nobody will compensate for each other. So blistering will be more severe in the, it is almost there completely. So there will be blistering in the suprabasal blister will be there. Suprabasal blister will be there, and you know, because in the upper layer Desmoglein 1 is there in the upper layer, and Desmoglein 3 is more in the lower layer. Okay, and Desmoglein 1 is expressed less in the lower layer, so depending upon ulceration will be there. Now see the various so in Pemphigus, so these are the various types of Pemphigus. We know, I will be showing you the classification. We can divide either into Pemphigus vulgaris, foliaceus, paraneoplastic Pemphigus, Pemphigus vegetan, IG Pemphigus, and Pemphigus herpetiformis. This is the classification which I like. So overall Pemphigus is a group of disorder divided into Pemphigus vulgaris, Pemphigus foliaceus, paraneoplastic Pemphigus, Pemphigus vegetans. Okay, Pemphigus vegetans, they can coexist. The vegetating lesion can even exist in the Pemphigus vulgaris also, but it's a separate variety, Pemphigus vegetans. And IgA Pemphigus. IgA Pemphigus is very, very important to understand. Okay, then Pemphigus herpetiformis, which will look like a dermatitis herpetiformis because of the grouped lesions. So in Pemphigus vulgaris, okay, it is the IgG type of antibodies. Okay, and overall this is common among the Pemphigus. And you can see autoantigens are Desmoglein 3 and Desmoglein 1 both, because these are cadherins, calcium dependent adenosine molecules, which are transmembrane molecules of desmosome. So there will be involvement of, okay, mainly oral mucosal lesion affecting the gingiva, palate, floor of the mouth, buccal mucosa, lip, tongue, nasal, even pharyngeal mucosa. The pharynx, you know, when you are entering the inside, okay. So behind your one tonsil, there is a pharyngeal layer, pharynx. So pharyngeal will be involvement in laryngopharyngeal. So that history is very, very important. If there is a hoarseness of the voice when patient is talking to you, that means there is a laryngeal involvement. Okay, there can be odinophagia when they are, so odinophagia history is very, very important. So laryngeal mucosa, nasal mucosa, pharyngeal mucosa, this is a favorite examiner question. So what are the different mucosa can be involved? Urethral mucosa, you have to examine, okay, genitalia, glans penis, vulva, perianal, okay, conjunctival mucosa. So sometimes they ask you what are the different mucosa. You should have a good knowledge about that. So don't miss your examination. You have to examine all the mucosa. Buccal mucosa, labial mucosa, gingiva, okay. Gingiva can be involved, okay. So then Pemphigus foliaceus, it is Desmoglein 1, and the blisters are very, very thin walled blistering, and very small blisters will be there, very fragile. Most of the time you're only seeing the, the puff pastry like scale, very classical puff pastry like scales will be there. So puff pastry or cornflake like scales are there, puff pastry or cornflake, and sometimes patient can present even in the erythroderma. Okay, so in Pemphigus foliaceus, no mucosal involvement. So in the history, we have to very, very clear that there is no mucosal involvement. Okay, so they are flaccid, they are fragile blister, puff pastry like scales, crust affecting seborrheic area. Then you have the examination will be telling that they are present in the mainly scales, your seborrheic area like scalp, face, peristernal area or interscapular area. Very, very important. Peristernal, and interscapular. The upper back, upper chest, mainly upper back, upper chest are involved, and the face is involved, scalp is involved. Now coming to the paraneoplastic pemphigus, that forms around 5%. I had a good exposure with these patients during in the institution. I have even presented posters and papers on the paraneoplastic pemphigus. Those were mainly the Castleman tumor. Castleman tumor is basically the lymphoid, lymphoid growth in the mediastinum, and one I had even a pregnant lady with a tumor. So the name suggests paraneoplastic pemphigus means there is a coexisting malignancy, because what happened in the malignancies are having a lot of antigens, and those antigen can mimic, because of the molecular mimicry, our cutaneous antigens, or here the desmoglein antigens or desmoplakin antigens, they are mimicking. So basically when our body try to target that particular malignancy, to get rid of that, we are targeting by our immune system. So in actually what happening is actually subsequently we are targeting our own skin also, because those antigens are somehow, because of molecular mimicry, match our cutaneous antigen. So we want to target, so that's why there is a destruction, there is a collateral damage to the skin. So, okay, so that's why paraneoplastic pemphigus occur with the malignancies, mainly lymphoproliferative malignancy, and non-Hodgkin lymphoma is on the lead, on the top of the list. Non-Hodgkin lymphoma, even you can get in leukemia also. Okay, leukemia, non-Hodgkin lymphoma, Castleman tumor. So these are the things you have to consider. Okay, so there will be not only antibody, and there are a lot of antibodies, because I know this, because malignant tissue can produce lot of antigens, so they can mimic a lot of things. So mainly the plakin group is affected. You remember the plakin group? The plakin family was mainly present in the outer plaque of desmosome, like even the even you remember the DEJ, when you are the DEJ, the plectin I showed you, the bullous pemphigoid like antigen I showed you, the DEJ, plectin is present, PP230, PP180, anvoplakin, periplakin, plactin. These are so many on antibodies are there. Then we can even do the test also. This anvoplakin is available. Anvoplakin ELISA is available. So anvoplakin, periplakin, plactin, BP230, BP180. Okay, desmocollin 1, epiplakin, desmoglein 3, desmoglein 1. So there are a lot of. So remember, even the inner plaque is involved. Inner plaque means inner plaque of the desmo, that is the desmoplakin 1 and 2. Cadherins are involved, desmoglein 3, then anvoplakin, periplakin. This anvoplakin, periplakin, you remember, even they were utilized in making the cornified cell envelopes. Okay. So the classical feature of paraneoplastic pemphigus is a recalcitrant stomatitis. The stomatitis is very painful, very recalcitrant. It does not heal with any of the treatment. It is very recalcitrant. So the word recalcitrant you have to use when you are telling. So severe mucocutaneous lesion with erosion and ulcers involving even the tongue. Verminal border involvement is very classical. Nasal, conjunctival, genital mucosa, skin involvement are polymorphic, and the lesions are very classical. You will be having EMF, erythema multiforme, like targetoid lesions will be there. Okay, you can have a lichen planus, like lichenoid lesions can be there. So the polymorphic lesions, are actually telling you that it is actually a paraneoplastic pemphigus. So you are having blisters. So one lesion is blister. You are having a blister. You are having a lichen planus like lichenoid lesion. You are having EMF like lesion. You are having pustular lesion. Okay. Okay. So you are having a lot of varieties of lesion. So the recalcitrant stomatitis with polymorphic lesion, that means you are telling actually you are having a patient of paraneoplastic pemphigus, and mainly they are having lymphoproliferative tumor, lymphoma, leukemias, even sarcomas and carcinomas also. Okay, so pemphigus vegetans is another variety of pemphigus, that is 1 to 2%. IgG antibodies are there, desmoglein 3, desmoglein 1, and periplakin. Okay, so periplakin is additional to the desmoglein in pemphigus vegetans. So periplakin is additional. The lesion will be papillomatous, vegetative, hypertrophic lesion. Very classical word you have to use is papillomatous vegetative plaque. Papillomatous vegetative hypertrophic plaques, and they mainly affect the intertriginous area like axilla, inframammary folds, umbilicus, even inguinal crease, anogenital skin, scalp, neck. Flaccid blister. Initially, it will start as a blister. The important thing is that they'll be having a fetid order, the malodorous. They will be malodorous. So you will be telling that malodorous, vegetative papillomatous hypertrophic plaques are present. Okay, these are the intertriginous area. Okay, and we will study about what is a Newman variety. Newman and Halopio are the two varieties. The Newman, as the name suggests, new. There are the new lesions which are not okay, and they are mainly having a papillopustular lesions, and the late lesions are called as Halopio lesions. Okay, so we'll be seeing the thick hyperkeratotic vegetative Halopio lesions. Okay, and then is the IgA pemphigus. See, the normal pemphigus is different from IgA pemphigus is that, so desmogleins are same. Desmoglein 3 is also there, desmoglein 1 is there. Only thing is that IgG antibodies are not there. When you check, when you do the checkup, when you do the DIF or immunofluorescence, you will be getting IgA. So why it's called IgA pemphigus. Instead of IgG, we are just getting IgA. The target is same, desmoglein 3, desmoglein 1. Only desmoglein 1 is extra in that. You can get even intraepidermal neutrophilic type of variety IgA pemphigus, or you can get SCPD. Okay. Subcortical pustular dermatosis, SCPD variety. There are two varieties of IgA pemphigus. We will see in the subsequent slide. Okay, and this when this intra IEN variety is there, IEN variety is having a very classical sunflower lesion. I will be showing you what is sunflower lesion, because the pustules, mainly here instead of vesicle, additional to vesicle, they are having pustules, and this pustule will coalesce to form a circinate or annular lesion with a central crusting. It's very classical of IEN variety of IgA pemphigus. And SCPD can even mimic your AGAP syndrome, acute generalized exanthematous pustulosis. So this is SCPD is one of the differentials of the pustular dermatosis. Okay, so when you are examining the patient, when you see a lot of pustules, lake of pus, you are seeing lake of pus or pustules you are seeing. So please, whenever any patient is having lake of pus or pustule, you please think about this IgA pemphigus. Please, they can have normal blister, fragile blistering also. Plus, they can have mainly pustular lesions also. Then come Pemphigus herpetiformis. Pemphigus herpetiformis is again desmoglein 3, desmoglein 1, and DSC is not that bad variety. It is additional thing is that one is it can mimic dermatitis herpetiformis. So there will be severe pruritus. They can be erosion, pustules, and the lesion vesicles. These lesions are clustered. That's why it's called herpetiformis, because they are having a herpetiformic or zosteroform arrangement. Herpetiformic arrangement. So overall, pemphigus is divided into pemphigus vulgaris, which is 70%, pemphigus foliaceus 10 to 30%, paraneoplastic only 5%, pemphigus vegetans 1 to 2%, IgA pemphigus again less than 2%, pemphigus herpetiformis less than 2%. So this is a classification of pemphigus. I was telling you, sometimes they classify as without subcategorizing it. Sometimes they classify as only pemphigus vulgaris, pemphigus foliaceus. So pemphigus vegetans, as I told you, because I told you pemphigus vulgaris vegetating plaque can coexist. So pemphigus vegetans is actually considered as a sub-variety or a variant of a pemphigus vulgaris. Again, pemphigus herpetiformis is considered as a subcategory of a pemphigus vulgaris. In some different books are mentioning different. So even you mention all them together also it's okay. Otherwise you can sub-classify them. So basically you can, main category is pemphigus vulgaris, pemphigus foliaceus, paraneoplastic pemphigus, atypical pemphigus or drug-induced pemphigus, and IgA pemphigus. Definitely IgA is different. Okay, pemphigus foliaceus is different. So two things you can put under pemphigus vulgaris. One is pemphigus vegetans or pemphigus herpetiformis as a variant of that. Okay, in pemphigus foliaceus you can put two more variant, that is a Fogo selvagem. Fogo selvagem, you know, it is happening in Brazil area or in this South America where there's a lot of jungles are there, and there is they think there is a genetic predisposition for them because it is found in mainly that area. Some race predisposition is there, some related to their race, related to the their genetics. Okay, because till now they are not understood. They think it's a multifactorial, and sometimes even they think it is because of the bite of the simulium. Even they are Lutjomaya sandfly also. Initially, we were thinking this is the simulium bite, but most of the books are mentioning about simulium bite. Some are mentioning about the sandfly, the Lutjomaya bite. So it's it's a bite of some insects. So insects is causing something. So is this related to sunlight, photosensitivity? So you have to take history of photosensitivity. It is mainly in some races, so it is tough to get Fogo selvagem patient, also called as endemic pemphigus foliation. Fogo selvagem means the burning wildfire. The meaning is wildfire. Fogo selvagem means wildfire. The lesions are like again cornflakes, like erythrodermic picture, very erythrodermic picture. Scaling is there, too much scaling is there. You can get, there is a crusting, scaling, okay, like a puff, pastry type of scales can be there. It is almost covering the entire body. We will see the various presentation can be there, not only erythrodermic, they can present even mild variety. So Fogo selvagem, if you see Fogo selvagem, why it is put under pemphigus foliaceus as a variant? Because immunologically, histopathologically, or by DI finding, they are actually mimicking, they are showing the features of pemphigus foliaceus, because histopathologically they are like that. So Fogo selvagem and pemphigus erythematosus are variants of pemphigus foliaceus. So pemphigus erythematosus, the name suggests erythematosus. So it is actually a combination of SLE and their pemphigus foliaceus because they are having. So they will be getting even the normal immunofluorescence of the pemphigus, plus you will be getting the band lupus band test positive. They'll be having dual. You will be having they'll be having a intercellular fluorescence as well as they'll be having a fluorescence because you know the antibodies are even binding to the basement membrane zone BMZ also. So they'll be having a dual fluorescence will be there. So that's why that showed that these patients are not only having SLE, they are having pemphigus also, and they had a antibodies almost to, and even they are having ANA positivity. So SLE with pemphigus is basically pemphigus erythematosus. So they'll be having a classical lesions, the crusting, erosion, ulceration on the butterfly area of the face. Okay, so that is very, and the other seborrheic areas can be there. So they have put under this pemphigus foliaceus. So you understood, under pemphigus vulgaris we will be discussing pemphigus vegetans and pemphigus herpetiformis. Under pemphigus foliaceus we will be discussing Phogosylvagem, pemphigus erythematosus. Then we have got paraneoplastic because of lymphoma, because of sarcoma or carcinoma, because of molecular mimicry. Then we have atypical pemphigus where you cannot designate which one is that. Drug induced pemphigus because of the drugs, you know, they are having thiol containing drug or non-thiol based drug. So penicillamine was a D-penicillamine, which is not used nowadays. D-penicillamine is one drug which can cause a pemphigus foliaceus like picture. So, and there are non-thiol based drugs also, like your penicillin, amoxicillin, penicillin and all, which can also cause pemphigus picture. They can also call, they can trigger a pemphigus, or because triggered pemphigus means you are having a genes for that, you are having HLA-DRB1 or HLA-DRQ1. So these HLAs you are already having DRQ1 or HLA-DRB1, whichever this, you know, this HLAs, or you are having genetic basis, you are having genetic predisposition, and you take that drug, and that drug actually can trigger the pemphigus. It is called as triggered pemphigus also. Okay, and triggered, why it is happening we will be seeing, we will be showing you. Okay, and then IgA pemphigus, and so this is another classification, so you can follow any of them. So that's why, so you can say according to the histopathologically, you know, they can have a deep pemphigus or a superficial pemphigus. Okay, but I prefer this classification. I prefer the earlier one which I already mentioned. So this is just for addition, that if somebody asks you about according to depth, then you can mention that deep pemphigus above the basal cell layer, it is a pemphigus vulgaris, most common and most severe. Pemphigus vegetans, again I told you, it is a rare pemphigus vulgaris variant only, and because vegetating lesions in a pemphigus vulgaris patient tells you that lesions are actually healing well, there is a reepitheliation. Okay, so drug triggered pemphigus, again it unmasks the pemphigus vulgaris. So you can have drug triggered pemphigus foliaceus variety also, the pemphigus vulgaris also. Okay, D-penicillamine causes foliaceous variety. Superficial pemphigus means we are actually talking about the pemphigus foliaceus. This is according to the depth of the cleft, according to histopathology. And pemphigus foliaceus is one variety. Pemphigus erythematosus. Okay, we told you you can either put as pemphigus erythematosus as a variant of foliaceus only, and then pemphigus herpetiformis, but actually it comes under the pemphigus vulgaris. Now the question is senior Usher syndrome. They asked you what is senior Usher syndrome? It is another name of pemphigus erythematosus. So senior Usher syndrome is another name of pemphigus erythematosus. So senior Usher syndrome. Please remember, senior Usher syndrome is actually another name of pemphigus erythematosus, where there will be ANA positivity, photosensitivity, and lesions will be there on the butterfly area. Now this is a typical only classification of pemphigus foliaceus. I'm telling you what is you know, some books are classifying foliaceus as classic foliaceus, then endemic foliaceus, and erythematous foliaceus. Okay, so this is taken from again prestigious journal. So tell you that sometime, you know, they expect you to tell this already covered. We already know that pemphigus endemic pemphigus foliaceus is there, pemphigus erythematosus is pemphigus foliaceus, but these are the names you can category, you can, you know, these are the better terms you can use, like classical. Classical means that means you are not talking about endemic, you are not talking about the erythematosus variety as also senior Usher syndrome. So you are actually talking about the classical. Classical means the blistering is subcorneal. All are having subcorneal blistering or in the granular layer. So basically subcorneal cleft will be there in all the three, and all are having Desmoglein 1 because they are histopathologically and immunologically they are similar. Okay, pemphigus erythematosus you will be getting a malar region, and Pemphigus foliaceous, the moment we say it's a type of pemphigus foliaceous means the areas will be seborrheic. Seborrheic with malar, it will become erythematosus. Okay, so seborrheic area will be involved. So this is pemphigus erythematosus. This is also called as senior Usher syndrome. Very important MCQ, senior Usher syndrome. It is a localized variety of pemphigus foliaceous, scaly crusted lesion. You will not get intact blisters here. You will never get. You will only get scales because the blisters are very tiny. They are very fragile. When they will come clinically to you, by the time it will become scale. So they rupture very fast. Okay. So scaly crusted lesions of pemphigus foliaceous appear in the malar region of the face and other seborrheic area. Immunological features of both LE will be there and pemphigus will be there. As I told you, there will be lupus band test will be positive, and when you do the ANA profile, ANA will be positive. They will be having IgG and C3 on the cell surface, and you will be having this. There will be lupus band test will also be positive. Okay. And in circulation, there will be ANA positive. This is just a combination. The name itself, pemphigus erythematosus, SLE with pemphigus. Okay. So it's a type of pemphigus foliaceous. Okay. So what is IgA pemphigus? IG pemphigus, I told you there are two varieties. One is intraepidermal neutrophilic variety and one other is SCPD variety. In intraepidermal neutrophilic variety, you get a sunflower-like configuration. The pustules will coalesce, you know, will coalesce to form annular or subserrate lesions, and there will be central crusting. Okay, this is like a sunflower lesion. So whenever you are seeing such type of sunflower lesion, it is almost like leading to your diagnosis of intraepidermal neutrophilic type variety. You can put a differential of that. Mostly the axilla and groins are affected, to intertriginous areas are involved. So there will be flaccid vesicles or pustules. There can be vesicle, there can be pustules. Pustules, you can see, pustule. You know what is pustule. So it is called as intraepidermal neutrophilic type. IN variety means intraepidermal neutrophilic variety. So obviously you can use Dapsone as a treatment because whenever neutrophils are there, you can use Dapsone. We will be discussing Dapsone in our next class. Another is SCPD variety. This is actually all the lesion are like sunflower like lesion. You can get even fragile blisters. You can get pustules. You are not seeing pustule at this situation because they have already coalesced. They have dried up. So you can say they are all dried up lesion. They are crusted lesion. Okay. This is, you can see a tiny pustules in that for D image. In the D image, you can see some tiny pustules. Okay. This is taken from one journal. Okay. Clinical Dermatology journal. And I have given credit to that. This is basically your SCPD variety, subcortical pustular dermatosis variety, and they can treat even retinoids are you retinoid because neutrophils are involved. So here again the pustules will be having coalescing to form large lesions, succinate lesions. They can be even lakes of pus. So this is actually a SCPD variety of IgA pemphigus. Some books even keep it as a separate category or separate disease also. So what is drug-induced pemphigus? Drugs may exacerbate or induce pemphigus, especially thiol containing. I told you all the pril, captopril, enalapril, all the pril drugs, captopril drug and penicillamine. Penicillamine are actually containing thiol. They can actually lead to a pemphigus. And non-thiol like penicillin and cephalosporin. Cephalosporin also non-thiol. The enalapril is a non-thiol and penicillin is cephalosporin. If you can remember, please remember. Even piroxicam, please remember pyroxenam, pyretinol. So there are a lot of P's: pyretinol, penicillin, piroxicam. I used to remember by the so many P's: pyroxicam, pyretinol, penicillamine, okay, and penicillin. So they are the things. So pemphigus foliaceous and pemphigus erythematosus are common pattern. Circulating autoantibodies with the same antigenic specificity will be there, and they actually recover smoothly. Okay. Okay, they will recover smoothly. This is again because of the molecular mimicry and destruction of the desmosome. So pemphigus, like substance such as the food which you have to avoid is very, very important. I always tell them to avoid, the banana, a lot of nuts. Okay, that is, a lot of problem with the mangoes. Okay, so even when we were in the institution, we used to put even drugs to be avoided and food to be avoided, and we used to paste behind the wall of the patient where the patient is admitted, and we used to give him separate paper on these things are mentioned. It's very, very important. Okay, so please write, always give them food chart or drug chart that these drugs should be avoided in the future. So substances such as thiol, thiocyanate, phenol and tannins, very, very important. These phenol and tannins are present in a lot of fruits. Okay, phenol and tannins. And thiol, you know, all this garlic and onion, which are commonly eaten in our India, garlic and onion, they are containing thiol. Okay, they can cause pemphigus. Food, they can even exacerbate the pemphigus. This should be avoided. And substances which are containing tannin. So always remember thiol, tannin, thiocyanate, tannin, and phenol. Thiol, thiocyanate, tannin, and phenol. There are three T's. There are three T's: thiol, thiocyanate, tannin, and then finally phenol. So phenol containing foods are very, very bad. A near complete list which is given here: vegetable like garlic, onion, turnip, broccoli, radish, cabbage, cauliflower, potato, leek, shallot, chives, tomatoes. And out of the tomato is very, very important. Always remember, try try to tell the patient that avoid tomato, garlic, and onion. Overall, these are very, very important. And the fruits, you should avoid mangoes, and you should avoid dry fruit as much as possible. Other fruit we should avoid is raspberry, avocado, cherry, cashew, banana, cranberry, guana, pear, walnut, peach. But what I tell my patient is banana and mango, nuts, garlic, onion, tomato. These are the broadly which I tell my patient. Okay. Ice cream, candy, they can contain all the tartragine, benzoate, coloring agent, nutrition supplement. They can also cause problem. Even wine, beer, drink should be avoided. Okay, and the Brazil, this is another theory they say, because Brazil river water contain high tannin, so tannin could have been the cause of this Fogo salivarium. Fogo salivarium in short means endemic pemphigus, okay, which is endemic in Brazilian area of South America. So what is the mechanism? Because this thiol containing compounds in garlic like allyl mercaptan or allyl methyl sulfide, they ask you sometime, what is that thiol containing thing? Allyl mercaptan, allyl methyl sulfide, all these are allyl mercaptan, allyl methyl sulfide, allyl sulfide. They are actually containing thiol and they are present in the garlic. Have been found to induce acantholysis in vitro. So the process is they can cause loss of cohesion of the keratinocyte, which is called as acantholysis. Then isothiocyanate present in mustard oil. They are of two types. Immunologically, they can be immunologically injury like allyl and benzyl isothiocyanate, or irritant. Sometimes even irritation because of the destruction. Irritant, what are they doing? There is a causing direct destruction. That is called phenyl isothiocyanate. They can cause irritant compound, can cause this type of pemphigus. Phenolic compounds such as urushiol. You know, urushiol is present in the toxicodendron family of the plant, which are known to cause allergic contact dermatitis. You remember the poison ivy and all these things, they can cause blistering. Okay, the similar event can be expected in acantholysis of pemphigus, because phenolic compound can cause acantholysis. Okay, mango, pistachio, cashew again belong to the same family of the plant. Other phenolic compound like aspartame, you know, that's artificial sweetener which you are using, aspartame is not good for them. Food additive like coloring agent, preservating agent, cinnamic acid, even present in the cinnamon, apple, grape, orange, pineapple, and tomato juices. They are having phenol. So please remember phenol. Avoid phenol. And okay, wines. Tannins are naturally occurring polyphenolic compound. Tannins are also polyphenolic compound, which are considerable biological activity. They can even cause acantholysis. So if they ask you in short, what do they do, these foods and these drugs? They causes acantholysis. Okay. Food stuff containing tannins include variety of things: cassava, eggplant, raspberry, cherry, okay, nuts, walnut, coca, coffee. It is not possible to avoid everything under the sky. So broadly, you can tell them to avoid the nuts, banana, don't eat mangoes, okay, avoid tomato, avoid onion, garlics, try not to drink wine and all these things. So that's enough, that suffices actually. So what are the rare manifestations? Sometimes they will get only scalp lesions. Sometimes they will get only dyshydrotiform eczema-like presentation. So please remember, pemphigus vulgaris can have even some enigmatic presentation also. So whenever you are getting only recurrent paronychia, there is only recurrent paronychia. Again and again you are getting onychopedesis, onycholysis. Even there is only nail problem is there. You are getting again a bleeding in the nail. So sometimes localized presentation of pemphigus vulgaris, because so you have to think about that. Even sometimes they have a plaque, the crusted OG plaque on the scalp, which look like even squamous cell carcinoma, or can look like eczema on the scalp. So because this hair roots are very, very rich in desmoglein. So because that's why even you can take hair for examination of desmoglein. Okay, you can do the checkup for them, even fluorescence checking for the hairs also. So these are the rare manifestation like isolated crusted plaques on the face or scalp. Isolated plaque. Then you may have to give intralesional steroid also. That is the role of intralesional triamcinolone. No, we are giving in a crusted plaques. We have okay, and not healing, because scalp lesions are very difficult to treat, especially scalp lesions. So remember, if they can ask you what are the lesion which difficult to treat, you can mention about the scalp lesion. Nail involvement, they can be paronychia, subungual hematoma, onychometasis, back, and on the tongue they can have just macroglossia, and the Premlata sign, the cerebriform tongue is seen in Pemphigus vegetans. So that is the Pemphigus vegetating variety. Pemphigus is a cerebriform tongue. So that is very important. So macroglossia. So these are the other presentation, like even foot ulcer. Sometimes foot ulcer. There are case report of dyshydrotic eczema which actually turned out to be Pemphigus. Okay. This is very important. So next slide is, okay. So which I already covered the classification of autoantigen, which we have already seen that in paraneoplastic pemphigus, the antigens are very different, like plectin, envoplectin. Plectin, you remember in our DEJ, it was present in the dermoepidermal junction, you remember? Okay. In the hemidesmosome, the plectin was present. And epiplectin, very important, desmoplectin. Desmoplectin is present in the inner plaque of the desmosome. Envoplectin, periplectin, BP230, envoplectin, periplectin were even required for the quantified envelope. Desmoglein 3, desmoglein 1, desmocolin. Desmocolin is just like desmoglein 1, which is also transmembrane in the desmosome. So paraneoplastic pemphigus. So this is Pemphigus vulgaris, mucosal dominant, or if it is a mucosal dominant, you can have to use this word, mucosal dominant. This is desmoglein 3. When it is mucocutaneous both, desmoglein 3 and 1 both. Pemphigus vegetans, we have already seen in Pemphigus vegetans, I told you, 1 and 3 will be present, plus desmocolin can be present. Okay, so desmocolin is present in Pemphigus vegetans. Desmocolin is also present in Pemphigus herpetiformis. I am telling in addition to desmoglein 1 and 3. So Pemphigus herpetiformis, desmocolin is present. And you can see the antibody profile of Pemphigus herpetiformis is just like Pemphigus. That's why it is a variant of Pemphigus. And Pemphigus foliaceus is only desmoglein 1, and Pemphigus erythematosus it is again desmoglein 1. Okay, that's why this Pemphigus erythematosus is a subtype of Pemphigus foliaceus, because it is immunologically, histopathologically, there is a subcorneal blistering is there. That's why they put under Pemphigus foliaceus. IG Pemphigus is totally separate because the here immunoglobulin is IgA, and in IG Pemphigus it is desmocolin 1 antigen. Okay, and intraepidermal, till now we don't know. It is the intraepidermal is a neutrophilic variety, a subcorneal pustular variety. Okay. You can see sometimes they can just present as the lips. There are the ulcers over the lips. You can see here. Okay, this is on the crusted plaque. You can say crusted erosion. You can say crusted erosion or ulceration. So you can say eroso-ulcerative crusted lesion present over the lower lip. It is involving lower lip. So you can see this plaque on the scalp. This is a crusted plaque. It is actually it is sometimes even because of the yellowish color, it will look like a squamous cell carcinoma to me. Okay, but it is not a squamous cell carcinoma. It is a plaque having, which is you can say large eroded ulcerative plaque with lot of crusting, or you can say large eroded crusted plaque. Okay, this word should be used. You have to say there is a large erosion. It's basically a erosion, large erosion, or you can say because it look like a very wet, somewhere it is dry. So it is a large erosion. So it is a large large erosion with crusting, or large crusted plaque, large eroded crusted plaque also you can say. So these are the words in combination. This means the same thing. It's a crusted plaque. It is a large plaque. So it is a large plaque. You have to measure the centimeter. How much is the plaque? It is present on the scalp. How much centimeter is there? It is a large erosion with a lot of crusting, you can say, or you can say eroded crusted plaque. Okay, a large eroded crusted plaque, which is having this much centimeter. We can tell. Okay. And this is Nikolsky sign, very important. Nikolsky sign, if it is positive in Steven-Johnson syndrome or toxic epidermal necrolysis, or bullous ichthyosiform erythroderma, or in burn patient, then it is called a pseudo-Nikolsky. It is happening in the same way, but it is pseudo-Nikolsky because it is not because of acantholysis here. Okay, it is called a pseudo-Nikolsky. It is okay. It is a different things is happening. It is basically secondary changes. There is a necrosis. It is not autoimmune mediated. It is not happening in if it is not happening in pemphigus, If it is happening in this condition, it is called pseudo-Nikolsky sign. But they are telling you that where is the level of blistering. Okay. But what is false Nikolsky? False Nikolsky means, or it's called a Shackle-Lakoff sign. Shackle-Lakoff sign is a very important question in exam. Shackle-Lakoff sign is called as false Nikolsky also. It is seen in subepidermal blistering disorder like bullous pemphigoid and all this thing. What is happening is that this remnant of the remnant roof of the blister, when you pull away from the lesion, so what happens? There is an extension of blister. It make you feel that there is an extension of the blister. It is not Nikolsky sign. It is actually called Shackle-Lakoff sign. There is a extension of blister, but then it is not going to happen spontaneously, and this lesion will heal and it will not spontaneously extend. So this is called Shackle-Lakoff sign. So, and when the the Nikolsky sign means you are putting a tangential pressure, okay, or a shearing tangential pressure or a force, okay, on the lesion. If you are putting, it is called as Nikolsky sign. What will happen when you put this tangential shearing force or pressure, okay, on the lesion? What will happen? There will be epithelial detachment will be there. Okay, the blister will extend. So extension of the blister and epithelial detachment on tangential pressure or shearing tangential pressure is called as Nikolsky sign. If it is this blister is getting extended, and if you are doing in the 1 centimeter margin, if you are within 1 centimeter, but you are not doing on the lesion, or you are not doing on the lesion, you are doing in a perilesional area. If you are doing in a perilesional area, it is called as marginal Nikolsky sign. Okay, it's very, very easy, and I already told you after doing the Nikolsky, and if you are doing on other area, distant area, which is totally normal looking area, see, even there is a erythema, it is taken as an activity of the disease. Even there is a erythema. So please remember, you are supposed to do in a normal area. There is even no erythema, and if you can do just rubbing. If you rub the skin, put a tangential or shearing pressure. If you put by rubbing it with a thumb, or you can do with a finger, and if epithelial detachment is there, if epithelial layer comes out, okay, it is called as direct Nikolsky sign. So it is called direct. When it is done distant, it is called direct Nikolsky sign. It is done on the normal skin. If it is done on the lesion, the proper Nikolsky sign is actually done on the lesion by the shearing tangential pressure or force leading to the extension of the blister or detachment of the epithelial layer. Okay, it is called as positive Nikolsky sign. And when you do it, what happens? The erosion which is visible is having if it is having a wet, glistening membrane-like look, it is called as wet Nikolsky sign, which is seen in active disease. That means the disease is very, very aggressive and active. And when you get a dry Nikolsky, if it is a dried up base, the eroded base is dry, that means the disease is inactive, or it is actually getting reepithelialized, getting better. Or if the lesion is very, very superficial, it's like Pemphigus foliaceus. So these are the possibilities, like Pemphigus foliaceus, where it is getting reepithelialized under the blister roof. Okay. So this is how we elicit. We have to put gloves, a sterile condition. Okay. And some books say, some school of thought is that never do it, but ideally for exam purpose, and I do practically. But some say because I already the blistering, if it is quite evident, why do you do it? Because you're already having ELISA. Because ELISA is quite available, you can quantify the Desmoglein level. How much is the Desmoglein level? Whether it is less than 12, whether it is less than 20. If it is more than 20, you can even monitor the disease by Desmoglein level. We'll see it. So this is a classical pathognomic lesion. You can see very, very, very classical. You can see here they are flaccid blisters. You have to use the word flaccid. They are flaccid blisters are there. See, sometimes patient will say that if they initially develop areas of redness, and on the areas of redness they develop blisters, and finally it ruptured to leave behind the painful erosion, or then they dried up. So you can say history suggestive of flaccid blisters, the fragile blisters, which you can tell the patient thing, and in such a way that history suggestive of. This is the way we tell the patient things. So actually we are trying to prove our diagnosis. Okay, so this is very classical. I told you the mucosal involvement is very, very classical here. Okay, there is a ulcer here. There is a ulcer. See, erosion is superficial, ulcer is deep, and there is a there is a desquamation here. Okay, this mucosal layer is actually sloughed off. It is getting sloughed away. You can say this sloughed away mucosal layer leaving behind a there is a erosion here, and sometimes you can get the involvement of pharynx, even esophagus. I already mentioned in the beginning esophagus involvement in the form of esophagitis. It is causing desquamation. Complete, it is causing desquamative, type of esophagitis, that when the complete layer of the mucosal layer of the esophagus is lost, superficial layer is lost, it is called as esophagitis dissecant superficial. This is one of the question they can ask you in exam. What is happening in the, when you do endoscopy, you will see this picture. And especially when the patient is having a history of heartburn and when they vomit, the esophageal cast come in the vomitus, or they're having a lot of dysphagia, odinophagia. You have to, think about even things happening in the esophagus. So esophagitis dissecant superficialis. This is a term for that. Esophagitis dissecant superficialis can happen in the esophagus. So you have to remember all the mucosas can be involved. For the eye, you have to send to the ophthalmologist for the care, and for the ENT checkup is very very important. And ENT checkup is very very important. Okay, and you need a dental care, you need a oral hygiene. So that is very very important. So if you know the condition, then only you will understand. Next is, see, this pain is very very high in pemphigus patient. Please remember, pain is very very high because these erosions are very painful. So in the history I have to mention that lesions are very painful, the erosions are very painful. So they will start as fragile fluid filled lesion, or you can use the word history suggestive of. If you are saying patient language, then you cannot, then you have to use a non-medical word. But if you want to say some medical word, then you can say the word history suggestive of, like that means that he is telling something and which suggestive of. So there are fluid filled lesion, there will be fragile blisters, like here fragile bullae are, the blisters are there, which will rupture immediately or after some time, leaving behind erosion, which are very painful, and subsequent there is a crusting. Okay, this is a very classical history you will get in pemphigus patient. So this is we are starting the case presentation. This is 39-year-old male presented to the clinic with 8-month history of painful lesions on his face and upper body. See, this is very very important. Painful word you have to use. You can use a lesion if you are not getting fluid filled lesions, you are just getting erosions or crusting, then you cannot use that word. So then accordingly you have to use. Okay, covering how much body surface area is not important in the presenting complaint. You can just say presented with this and this. This is obviously, these are like from journals, so they are giving a summary, but you will get an idea how to tell what are the words you are supposed to use, what is the vocabulary. So the patient has a crusted plaque. This is very very important. See, dermatology vocabulary should be very very fine. This is it's an art to tell the description of a patient. You have to know, you to again examine the patient and present the case. As many patients you will present, you will become more master. Okay, so these words should be like crusted plaque, very classical. When they say crusted plaque, you can imagine there are plaque with having a lot of crust with extensive erosion. So extensive erosions of his scalp, face, trunk, arm and thigh. Normally in some institution they go from upper to lower part, and they mucosa they put it separately, and mucosa and genitalia they put it separately, and then hair and nail they put it separately. In some institution they obviously mucosa, hair, nail and genitalia they will be separate, and one they'll be overall they'll be having a universal description. So I have worked in both the center where we used to have a universal description that lesions are present on this area, and they are sparing this area. Okay, so this is how, because this presentation, this is the presentation which I like and some most of the examiner. So you follow the presentation technique in your center. I have taught both the techniques to my student. So if sometimes they want the global, they want overall picture, that lesions from I'm not telling about pemphigus, I'm just telling in general lesions. These are the the papules or whatever the lesions are present, or this of this centimeter of this color, where extending present on this area like face, or in which sparing which all area. So sparing is very very important, because when we say they are present here and they are sparing that means you are leading to a situation where it does not affect that area. Okay, so that is very important. Like when you are presenting a patient of chronic actinic dermatitis or Parthenium dermatitis, so the sparing you have to tell. Even in the blistering condition, you have to mention which areas are spared. So which are involved, which are spared, you have to tell. And if you are getting some plaques, the smallest lesion of this area to the largest lesion on this area, so you have to know where is the largest lesion. So that should be in your description when you're presenting it case, that the largest lesion is present on the upper back of this and this centimeter. Okay, So, and the size of the lesion is ranging from this to this, and the largest is present on the this. So this is a global image of the patient, which normally I prefer, because this can give you this, you can imagine when the person is telling you. But you say face 2 lesion, neck 3 lesion, upper no, upper the anterior part of the chest, back this lesion, abdomen this lesion, lower back this lesion, arm, forearm, and it becomes very confusing. So imagine, so that but some institutions are following that. That is not wrong, because so you can present like face, then neck, then chest, then according to the top to bottom you can go, and then you can go mucosa separately, you can go hair and nail separately, and genitalia separately. So anyway, this patient will be separately, but instead of dividing the area, you can tell in the single description also the lesions are present on the face, neck, chest, back, sparing axilla, sparing groin, and all these things. So this is how I like, or this is the most this is if I feel better, slightly better when you plan, when you imagine a patient, and most of the journals are using this. So the important thing is that where are the lesion, what is the pathognomic, or you can say the primary lesion. See, if it is a blister, if it is a blister, it has, it has finally become crust. So crust is not a, like, primary lesion. You have to mention that if if they are pustules, or if like a papules are coalescing to form plaque. So papule is the primary lesion. So that finding a primary lesion is very, very important, because to know whether you are dealing with a papular condition or papuloscomas condition, scaly lesion, or you are dealing with a blistering condition. So you have to tell in your description that whether the blisters are present or not. Then actually, if you are either you are saying blisters or erosion, this is almost giving a clue that you are dealing with a patient who is having a blistering dermatosis, or a okay, there is a problem in the there is a blistering in the skin, erosion, ulcers. So your description should be like that. You should include your primary lesion. Subsequently, what is happening is also you should include secondary lesion. So the crust, erosion, whatever secondary things are happening, you should tell things I'm telling. Okay, the subsequent changes in them. So that is how you have to tell this. So this particular patient has crusted plaque with extensive erosion. You can use the word is extensive. Okay, extensive word is very, very important. When they are very large, or you can use the word large erosion or extensive erosion on the scalp, face, trunk, arms, and thighs. And now the very important point they are telling is there is no involvement of the mucous membrane. So they are almost telling you it's a condition which present with the erosion. So this is one of the the Pemphigus group of disorder presents as erosion. Okay, and these are also telling you about the areas also. Okay, they are also telling, but there is no involvement of mucous membrane. So either it is a Pemphigus, it can be foliaceous, or it can be a where there is no mucosal involvement. So if you see here, they have done the biopsy and it is showing subcorneal acantholysis. Okay, so subcorneal acantholysis with neutrophil in the upper epidermis and rare necrotic adenocyte. DIF, direct immunofluorescence, shows intercellular immunoglobulin. Consider, the chicken wire appearance will be there in Pemphigus vulgaris, but in the Pemphigus foliaceus, it is only the upper part of the epidermis which will be showing the fluorescence. So they are classically mentioning it is their intercellular immunoglobulin position consistent with the Pemphigus foliaceus. So ELISA was performed. ELISA is very, very important. You can do the titer. Desmoglein 1 was positive and Desmoglein 3 are negative. So almost they are clear it is a Pemphigus foliaceus case, because ELISA is telling you. Okay. So this is you cannot even tell the size here, because you just have to tell extensive. They are almost extensive. So this word will be very, very important. Extensive, crusted, plaques and erosions are present. Somewhere there are erosions, some there are plaques. So you have to use this word. Okay, actually presenting a Pemphigus patient is easy, not that difficult. And you have to tell what are the areas spared. This is you can see there is a cleft here. Okay, subcorneal acantholysis, subcorneal neutrophilic infiltrate is there. Here there are a lot of neutrophil you can see. Okay, and superficial perivascular lymphocytic inflammation is there. Very classical. So how will you distinguish Pemphigus? What are the differences in antibodies? Pemphigus foliaceus is only Desmoglein 1. It's just a repetition. There's Pemphigus vulgaris 3 and 1. Histopathologically, there will be suprabasilar acantholysis in Pemphigus vulgaris. Pemphigus foliaceus is very superficial. It is subcorneal. DIF will show intercellular IgG. Pemphigus foliaceus also intercellular IgG, but it is only on the localized to the upper part. And indirect immunofluorescence, we normally use monkey esophagus. Remember, monkey esophagus is very, very important, because monkey esophagus is rich in Desmoglein 3. And guinea pig esophagus can be used for Pemphigus foliaceus. Guinea pig esophagus for Pemphigus foliaceus. Monkey esophagus for Pemphigus vulgaris. What are the areas of involvement in Pemphigus vulgaris? Mucosal if positive for Desmoglein 3 only. Mucocutaneous if positive for, we already discussed it. Pemphigus foliaceus skin does not involve mucous membrane. Start with a seborrheic distribution. So your distribution will be like in the upper chest, upper back, scalp. These are all seborrheic area, face, seborrheic area. And the Pemphigus vulgaris, you will get a erosions in the mucosa, maybe a labial mucosa or a buccal mucosa or pharyngeal, or there will be flaccid blister. Sometimes the blister will collapse. It is called as collapsed vesicle, which will look like a whitish membrane, like will be collapsed. You can see it is a collapsed vesicle. Sometimes you can see collapsed vesicle. Sometimes you can just get a sloughing of the mucosa, or you can get an erosive gingivitis, erosions on the gingiva, erosive or desquamated gingivitis you can get. In Pemphigus foliaceus, it is crusted erosion with intact blisters will be there. Okay, crusted without intact blisters, because you will never get blisters in Pemphigus foliaceus. Never ever. Okay, because they are just like a cornflakes, like pasty puff like scales are there, very dry. What is endemic? Endemic variant of Pemphigus foliaceus is called as Fogo selvagem, which means wildfire in the Portuguese language. They ask you what is the meaning wildfire. Fogo selvagem share clinical, histopathological and immunological characteristic with classical Pemphigus foliaceus. That's why it is put under a variant and is distinguished from it by epidemiological aspect, namely higher frequency in children and young adults in the rural areas and in regions geographically known for high incidence of Fogo selvagem, beside the presence of familial case. So there is a family history, there is a racial involvement, there is a localized geography which is involved. The symptoms resemble like a burn injury. So most for Fogo selvagem patients live in a rural area, which explains how the disease came to Fogo selvagem or wildfire, a term that has been established in the medical literature. They also think it may be because of there's some salivary protein is there in the blood sucking insect, like the black fly like Simulium nigrimanum triggers the autoimmune response, because this is all molecular mimicry, which autoimmune response as a black fly's bite has been found to be more common in this Fogo area patient. These are the area which is very common. So this is what about. So Fogo selvagem, you can get 4 types of pictures. Sometimes they ask you, one is vesiculobullous variety, another is erythroderma. They can present as erythroderma, sometimes as a keratotic variety, which is treatment resistant. Keratotic means they'll be having a generalized keratotic plaques. Herpetiform means like beside FS, this variant can also present as Pemphigus foliaceus and Pemphigus vulgaris. They can get a herpetiform lesions also. Normally they don't ask this question, but this is for a general knowledge. Sometimes they can ask you what are the other varieties which are mentioned. So one is vesiculobullous variety, that is a bullous exfoliative. Rapid onset of flaccid vesiculobullous lesion with multiple erosions, sometimes with pustular content. When the vesiculobullous lesion develop in an annular succinate fashion, eroding, they can erode with a crust. They can resemble even tinea imbricata. They can resemble like a tinea imbricata. Erythrodermic, the entire integument of erythematous, the skin become red, desquamative with the presence of erosive, exudative, crusty areas. After ruling out other causes of erythroderma, the diagnosis of FS is confirmed by the laboratory test. We know histopathology and immunology. Keratotic, third variety. So they have vesiculobullous variety, the normal variety, the normal. Second is erythrodermic variety. Third is keratotic, and fourth is the herpetiform. Keratotic means there will be large keratotic plaques will be there. Okay. So 4 variety presentation of Fogo selvagem. You can see it looks like a erythrodermic variety. This is erythrodermic variety of Fogo selvagem. Okay, this is another picture of Pemphigus vulgaris. You can see here there are erosion, there is a crusting. So there are erosion and crusted plaques. These are crusted plaque and there are erosion. Okay, that is looking like a fresh. Somewhere it is dry erosion. This is like a wet erosion. There are crusted plaque and there is some hemorrhagic crust here also. You have to use this word hemorrhagic crust. Normally hemorrhagic crust signifies, or we are using in the cases of toxic epidermal necrolysis, or when there is a necrolysis of the keratinocyte. Even hemorrhagic crust lesions can be seen in paraneoplastic, but here it is there, so we have to tell there. Okay, we have to tell this. Medical history. So what are the medical history? See, you will be having a presenting complaint, then you will be having a HOPC, okay, history of presenting illness. So in HOPC, what medical history you should have when you are presenting a case of Pemphigus vulgaris? You must be having a questionnaire with you in the institution. Please follow that. I'm just adding more information, or just I just want to make sure that at least what I'm telling is there or not. So it is recommended to document the following point: specify the time of onset of the symptom, specify Functional symptom like pain. Pain is very, very important. Even you can do the pain scoring from 0 to 10, like they are having pruritus 0 to 10. So pain is scoring from 0 to 10, analog, visual analog scale. You can ask pruritus, intensity of dysphagia. You have to ask about dysphagia, how much is that? Ocular symptoms are there, ENT symptom like odynophagia, dysphagia, okay, dysuria, if there is a dysuria, anogenital. So you have to get all the, this history should be there in your HOPC when you're presenting a case to signify when any other mucosas are involved, like anogenital problems are there or not. Weight loss, because the patient is, because there is odynophagia and there is a weight loss, it is, if there is a weight loss and typical odynophagia, too many lesions, it is considered as a severe pemphigus only. So you have to do a hematological, oncological, endocrine, cardiovascular, infectious history also, whether there was a fever or not. All these things you have to take an infectious medicine, because sometimes pemphigus patient come as a secondary infection. Okay, because there is a loss of barrier, skin is lost. You have to take a other history also, whether they are having, when the systemic features are also, because when it is extensive, they are losing their electrolytes, they are losing, so they can have all the cardiological symptoms, they can have a respiratory symptom, endocrinological system. So try to get those type of symptoms also in your history. If and please, that is history of pregnancy, everything should be there, because that will be there in the beginning itself, about the pregnant or not pregnant or lactating on, because your immunosuppressive dose and the type of immunosuppressive will be decided by this. Ask for drug intake, because I already mentioned, we have already emphasized that drugs and food are very, very important, but drug history should be there, because it can be a triggered pemphigus or a drug induced pemphigus, because especially ACE inhibitor, angiotensin converting enzyme inhibitor, angiotensin receptor blocker, beta blocker, cephalosporin, phenylbutazone, pyretinol. I told you there are a lot of phenylbutazone, pyretinol, penicillamine, thiopronine, rifampicin, even D-penicillamine. They can cause drug-induced pemphigus. D-penicillamine can produce a pemphigus foliaceous-like picture. It will be considered whether to discontinue or not, because if it is, there is a see, always drug may not be a trigger or cause, because if they have been taking it, this is not in a temporal relationship. Just before the lesion, if you have taken drug and recently started, that you are thinking this is a temporal relationship, that link is there, then better to stop it or stop it. And the questionnaire, you have to take a quality of life when the patient, you are having a patient in your OPD or a consultant. If it is not an exam case, if it is better to do your DLQI scoring also, because life quality index is very, very important. And check for the updated vaccinations depending upon that, because nowadays COVID vaccination program is going on, so that is very, very important. So regarding the vaccination also, you should ask your medical history. Physical examination, I already mentioned, it is recommended to assess the following: the extent of the skin and mucous membrane lesion. See, normally we were taught to do PDI and we were taught to do abscess. Even many students have done thesis in abscess and PDI scoring. So PDI is nothing but pemphigus disease area index, or abscess is autoimmune bullous skin intensity and severity score. Abscess, they ask you what is abscess, they ask you what is PDI. You may not always necessary to know every point. It is little bit difficult to remember, because you should have a printed thing and then you can fill it up, because it is tough to remember the mark and the the weightage of everything. But we used to have a printed version and we used to get it and we used to fill it. So normally in university exam, you are getting very less time. So if you are free and if you are getting extra time, you can do it. Okay, but at least body surface area is very, very important to know the severity of the disease. So body surface area, you already know the rule of 9, and so you have to follow the rule of 9. According to the rule of 9, measure the body surface area plus the palm is equivalent to 1% body surface area. And please remember, the blood pressure is very, very important, because you are going to give steroids or whatever, and your body weight is very, very important, because medicines are measured. So you cannot just say I did not measure the body weight, I did not measure the blood pressure. You have to measure it. You have to know about the general condition like neoplastic, cardiovascular, whether it is a non-case of diabetes or not. So, and Nikolsky said we are performing. And now this is abscess scoring system. Abscess scoring system is, you can see they have a very, very classical weightage for the different type of lesion, like 1.5 weightage for erosive exudative lesion. When the lesions are erosive but dry, so the weightage become 1. I told you one dry lesions are a little bit better, because you have 0.5 means even lesions are reepithelialized but they are present is 0.5. Then according to the rule of 9, their head and neck is taken as a 9%. Okay, and left arm including hand they have taken as 9%, right arm including hand 9%, trunk, front and back they have taken as 36%, leg 18%, leg 18%, genitalia 1%. So this is according to body first. So what do they do? Skin involvement, they will be having a total score of skin involvement. So what will they do? They will multiply the body surface area into the weighting factor. So this will vary, the total will vary from 0 to 150 points. Okay. Oral involvement is very, very important. That's why I showed you the picture of oral cavity, that what is, whether it is a upper gingival mucosa, lower gingival mucosa, upper lip mucosa, lower lip mucosa, left buccal mucosa, or is a right buccal mucosa. You have to tell whether right or left. Then tongue, floor of the mouth, what is hard palate, soft palate, and pharynx. Okay. So the total score will again vary from 0 to 11, where there is a, so you have to enter 1. If lesion is present on the upper gingival, just present, put a 1. If the lesion is present on left buccal mucosa, present as a 1. No lesion, 0. So you will total see either 1 or 0. So these are the places, 11 places. So you are examining 11 areas, and the total score will be 0 to 11. So you have to add this score. Okay. Then comes the severity. So this was skin involvement. This is oral involvement. Now third thing which we are checking in abscess scoring is a severity. Severity means how much discomfort during eating or drinking. So they have given a different point, different level. See, even you are drinking water, it is level. This is 1, soup 2, yogurt 3, custard 4, mashed potatoes 5, baked fish 6, white bread 7, apple 8, fried streak or whole grain bread, it is 9. So they have a different level of that. Okay, different level of that. So, and now they have a table that what is the factor of discomfort. It is 1 means this, the moment you like there is a pain and bleeding, and pain and bleeding occur only sometime when you eat this thing or drink this thing or never experience this problem. So according to that, you will be putting a factor of discomfort here, factor of discomfort here. So this is actually telling you the severity. The overall abscess has got 2 parts. One is the how much involvement, and involvement has again got 2 parts. Skin involvement or oral involvement. Skin involvement is according to the rule of 9 multiplied with the weightage depending upon wet lesion 1.5, dry lesion 1, reepithelial lesion it is 0.5. And when there is a oral involvement, 11 areas we are checking and whether present or not, 1 or 0. Okay. So this is the abscess scoring. Next is your pedi. We have to see the pedi. This is pedi. So this is also pedi. You can see pedi. There is a there are different anatomical location. So what they have got is that instead of involvement and the severity, they have divided into activity and damage. How much is the damage? So if damage, they are calculating that damage, they are calculating post-inflammatory hyperpigmentation or erythema. When the lesion goes away, okay, when lesion goes away, if it leaves hyperpigmentation or if leaves erythema, that is considered as a damage. So they have given if there is a post-inflammatory hyperpigmentation or erythema, if it is present, it is taken as 1. If it is absent, this is 0. So that is telling about the damage. So this is a damage score. So it has got 2 parts, activity and damage. Okay. So activity we are checking in different area. We are checking here. They have given a weightage to scalp also. Okay. Remember scalp, and scalp is divided into quadrant. 1 quadrant, 2 quadrant, 3 quadrant, whole skull. Okay. Okay. This is a quadrant basis, and they have divided various areas. One is anatomical basis. Anatomy first is anatomical location. Okay. Then they have this various location like ear, nose, rest of the face, neck, chest, abdomen, all these things they are checking. So first is erosion or blister or new. I told you, even there is a new erythema, it is considered as an activity of disease, or it is a, so if there is erosion or blister, it is activity. So 0 means absent. 1, 2, 3 is called as 1. That's why I told you. You cannot remember the weight. Very difficult to remember. So you have to have a printed version of this, and you can fill it. You can fill it. Try to have it, and and try to do it in every patient. So after doing some patient, you will even remember. But it is not possible to remember exact because these are long performa. So you have to fill it, and there is a performance. So at the end, you have to do the total also. Okay. So if it is 1 to 3, it is 1. It is 2 to 3 is 2, and they are measuring the size also. More than 2 centimeter, it is 1. Okay, and 2 to 3 lesions more than 2 centimeter. Then 3 more than 3 lesion. 5. We are giving the weightage activity is the more than 3 lesion, and they are more than 6 centimeter. Okay, and 10 if they are more than 3 lesions and they are at least more than 15 centimeter, or the entire area is involved. So you can see this PDI scoring because I cannot project it properly because it's a small slide, it's a big performer. Okay, then they have got this score of, then this thing you will be filling here under the category of ear, nose, chest, abdomen. Okay, so you will be writing here. So we are actually having a maximum score of 10, maximum score of 10, and 10 multiplied 12 areas. These are the 12 areas where you will be putting this number. So 12 area multiplied 10 is 120. The total score of activity in the skin is 120. So these are the 12 areas which we are checking: ear, nose, rest of the face, neck, chest, abdomen, back, buttocks, arms, hands, legs, feet, genitalia. So these are 12 areas. You have to fill this performer. You will get a total of 120. And damage, I told you again, you will be checking these 12 area with 1 or 0. So the damage score can be maximum 12 and 120 can be the maximum score of your activity. Then you are checking the scalp. Your scalp, the total score can be 10. You are giving at least 10. Okay. If so, the maximum, so you are checking out of 10. If it is 1 quadrant, 2 quadrant, 2, 3, it's very easy in the scalp. 3 and 4, you can remember whole is for whole scalp. If any lesion is more than even single lesion, if it is more than 6 centimeter, they are giving 10. So this total 10 score. And the active damage, so you have to divide into activity damage, every area damage. So damage is very easy, 0 or 1. Where PIH or erythema is there, absent, 0, 1, 1. So out of 1. So this you will be added to this, and finally you will be having a PDI of mucous membrane, absent 0. If the erosion or blisters are absent, 0, 1, 1 lesion, 2 to 3, 2. Okay, 5 more than 3 lesion, and 10 entire mucosa is involved. And again, but we are not checking the damage part here. Okay, we are just checking the activity here, and these are the, again they are checking the 12 areas including the eyes, nose, buccal mucosa. These are all mucosa: eye mucosa, nose mucosa, not the skin of that. Hard palate, soft palate, gingiva, upper gingiva, lower gingiva, tongue, floor of the mouth, labial mucosa, posterior pharynx, anogenital, and this is the area. So you have to remember this. Okay, so this is 120 here. Here again 120, it is almost 240, and 240 plus 10, it is 250. 250 it is okay, 250, and 12 is 263. 263 and 1, it is 264. Total is 264. Okay. So PDI range from 0 to 263. Okay. Where was the 1? Oh, it is absent. Okay. So 120 for the skin, 10 for the, yes, it was 263. Okay. So 12 for the mucosa, 120 for the skin, 120 again, for the mucosa, it was actually 120. Here it is mentioned is written wrong, and 13 point for the damage. So it is 263. It is not 1, 2, it should be 120 for the mucosa. We have just seen, no? So 120, 120, and 10, and 13 point for the damage. 12 was for the skin, and mucosa we are not checking the damage, and 1 was for the scalp. So 1 for the scalp and 12 was for the skin, so 13. 120 for the skin, 120 for the mucosa. So 240, 263, 0 to 263. Okay, this is PDI score. This is PVS scoring. I am telling these are very important. Okay, these are very, very important. PDI and abscess are very, very important. Other you just completion stage, so they can ask you what are the others. This is a PVS is there. They are checking the different type of this is a different variety. They have included the Nikolsky sign also. So PVS grading is there. Then Hermann Pemphigus grading. They can just tell the names. Okay, Hermann Pemphigus grading is there. Even they are checking the antibody titer level, Desmoglein 1 and 3 by the ELISA. I am doing this. Every patient I am doing Desmoglein 1 and 3 is very, very important. See, this ELISA is very, very important for patients. Okay, for monitoring when to stop the treatment, whether the patient is remission or not, or whether this relapse or not. Relapse is mentioned by the, again you will start getting the increased titer or presence of this. Kumar is actually easy. If you see the skin score, I remember this because body surface area, if you are not doing anything, at least do the body surface area. Less than 10% is called minimal disease. 11 to 30 is called as moderate disease. More than 30 is severe disease. Normally the treatment of moderate to severe disease is almost similar, but even you mention it is good. Okay. So again, Oral score minimal, moderate, and severe. Minimal means only mucosa is involved like pharyngeal. Moderate means there will be involvement of palate, pharyngeal or pharyngeal, moderate buccal. And severe disease, extensive lesions are there. Okay, so depending upon this is very subjective, very subjective. Case presentation. So coming to the case presentation, a 76-year-old male with a history of stage 2B squamous cell carcinoma of the distal esophagus. You may be thinking we are talking about paraneoplastic, but wait and watch. We are not talking about paraneoplastic always. So we have to, because the age is more. So anyway, patient is having malignancy also. So that means we are dealing with something related to malignancy. Type 2 diabetes, mellitus, hypertension, emergency liver disease with a bullous disease. So we normally use the fluid-filled lesion, or the patient is already non-case of blistering disease. You can say the patient was a non-case of blistering disease. I'm not telling about this patient as a whole. His symptom had started 5 months, very important, 5 months before, prior to the presentation, only oral ulcer. And he initially had only oral ulcer and dysphagia. 3 months later, he developed bullae. And you have to tell where they started. They started on the arms, and finally they spread to the torso and the leg. This is how we are going to present. They started here, they later spread to this and this area. Okay, and then finally there were erosion, ulceration, and even regarding the activity of the disease, you should tell that lesions used to start the red areas, or erythema. Initially erythema will be there. On the erythema, the patient used to develop fragile blisters, and they used to rupture, leaving behind the painful, and the pain score also you should tell. If there is itching, you should tell itching also. So the problem, the pain is there, because I told you itching is there, is a part of pemphigus herpetiformis. And pemphigus vulgaris, there is a lot of pain, and you should 0 to 10 you should have a visual. Off note, he had been diagnosed as squamous cell carcinoma of the distal esophagus 7 years prior and undergone radiation therapy, neoadjuvant therapy with cisplatin and subsequent esophagotomy. He had been in remission for 5 years. He denied starting new medicines. You want to rule out by new medicines, because drug-induced thing can be there. CT, chest, abdomen, 2 peaks prior to the presentation has shown no malignancy. Means there is no other malignancy except this squamous cell carcinoma. So because normally this paraneoplastic pemphigus associated with sarcoma, carcinomas, or lymphomas, and there is a weight loss over 5 months, but negative for fever, chills, night sweat. On examination, oral ulcers were there, diffuse tense bullae were there. This body surface is very important. So we are dealing with blistering condition. We are dealing with erosions, and painful is there. So we are actually dealing with a blistering condition. Okay. So we have to elicit, and you can see the moment you see this picture is very classical of pemphigus. No, you are seeing this. See, this is almost there is a slough of skin. This is an epithelial layer is coming. You not to say this way. You have to. You will be telling there are large erosion, and you can measure this erosion of size from this to this area, or you can just say extensive erosion also. If you cannot say the size from this and this, you can just say extensive erosions. You can say there will, you can say crusting present. Okay, the crusted erosions you can say. Okay, there there are. You can say some are crusted plaques. Some have already reepithelized. There is a hyperpigmentation. You have please mention about that already there is a hyperpigmentation, or there is a, if there are only you get erythema, you have to, here it's not there, but if there is only there are areas of erythema, please mention that there are areas of erythema also, because very important, because even there is an area of erythema, it tells you about the activity of this is a pemphigus vulgaris. So why it's not paraneoplastic? Because there is no polymorphous lesion, because in paraneoplastic pemphigus there is a recalcitrant stomatitis. Lesions will be lichenoid, EMF like, there will be multiple varieties. Here I am saying monomorphic lesions, they are not polymorphic. Okay, and this is another jet series. You can see that you can see their fragile, you can see the wrinkling in the blister, saying the fragility. Fragile blister will be having a wrinkles, like this. So this tell you this is a fragile, and they are see almost leaving behind erosions. And if you if you this, you can see the very classical moist membrane here, and these are blisters here, fragile blisters. These are finally healing with hyperpigmentation. This is a damage. We are giving a damage score. We are doing a damage score. Okay. You can see there is a reepithelization, complete reepithelization is there. Okay, but this is a case. You can see here is even tombstone appearance is there. This is the basal layer. Always follow the end of this. Start from here. If you see this, sometimes you will be confused. Is it subepidermal or suprabasal? It is suprabasal because you can see here tombstone appearance is there. You have to follow the blister. Always follow the blister. Okay. You can see a chicken wire appearance. You can see classical chicken wire appearance, fishnet appearance or chicken wire appearance is there, because there is an intercellular deposition of the antibodies. You can see fragile blister leaving erosions. Okay, these are some collapsed vesicle erosion. There is a erosion and ulceration of the lower lip. Here is a hemorrhagic crust. So whenever I see hemorrhagic crust, I will be thinking of paraneoplastic also, because mostly they are seen in paraneoplastic or other diseases. So what is Pemphigus vegetans? A rare variety of Pemphigus vulgaris, characterized by the vegetating erosion. There will be papillomatous surface, hypertrophic surface, mainly on the flexures. Oral lesions are present. You know, cerebriform tongue is there. Newman variety you will be having it. It is a Newman is a new early onset variety with a vesicle and bulla rupture, hypertrophic granulation tissue. So you have to use this word granulation erosions are granulation, very thick granulating mass. Granulation tissue will be there, granulation tissue will be there, vegetative mass will be there, edges are stated small, and pustules are there on the edges. So that is a classical feature of Newman. Newman is having edges which are studded with the pustule. This is the word we use, studded. This vocabulary has to be, used, because repeated using of these words will make you smart, okay, to give a good presentation. Okay, you can say the edge is studded with the pustules. Okay, very, very important. And the next variety is Halopew. Halopew varieties are basically edges are studded small pustule. It's a mainly is a vegetating plant. It's a vegetating plant. Newman is similar to Pemphigus vulgaris per prolonged. Halopew is more benign and spontaneous emission is there. So Newman is similar to Pemphigus vulgaris, but it is a bad variety. Halopew is a benign variety. So they can ask you which is benign. So Halopew is a benign variety. It goes for spontaneous emission. So Halopew is a good variety. So these are vegetating plaque. You can see classical papillomatous surface, hyperplastic tissue, no, hyperkeratotic. So I will not use the word hyperkeratosis because sometimes they don't like, because hyperkeratosis is a histopathological feature. Even in histopathology, if you do, you will get hyperkeratosis, acanthosis in this picture. Histopathology will show that. Even sometimes you can get eosinophilic pustules, eosinophilic microabscesses can be there in the epidermis in this Pemphigus vegetans. Eosinophilic abscess can be there, but you can see here a lot of erosions, papillomatous vegetating plaque, papillomatous vegetating plaque with areas of crusting and erosions present on the intertriginal, is you can say the genitocrural for this inguinal area, even extending to whatever areas, scrotum or whatever you can say. This is I think female, so labia majora and all this thing you can mention. So what is the recommendation? Overall, this is from the JARD. It was published recently 2018 in JARD article. So this is just a beginning. Sorry. Then we will be going for the management and treatment. Clinical presentation, review symptoms including type and timing, review current medication. This is very, very important because drug-induced pemphigus. And see whether any contraindication to corticosteroid, immunosuppressive, look for the pregnancy. Okay. Physical examination, assess the extent of the disease, assess the degree of disease damage. I told you any of the scoring you have to do abscess or PDI. In exam, if you don't get time, at least do the body surface area and have some idea about this scoring system. Okay. And if you have a printed version, you can get it. If they allow you to get it, then please fill it up. It is good. Histopathologically, you will be getting Pemphigus vulgaris intraepidermal suprabasal acantholysis. You know what is acantholysis? Is a loss of cohesion of the keratinocytes. Okay, they get separated because of the dissociation and disorganization of the desmosome. They get a primary acantholysis. Primary means when it is happening, the problem is happening in the desmosome, and secondary to the keratinocyte. If it is happening primarily to the keratinocyte, there is a destruction, there is a necrosis, and finally they sloughed away, becomes secondary. If there is some toxin, some damage, toxic damage to the keratinocyte, and they are just sloughing away because of apoptosis or necrolysis, then it is secondary. Can be because of chemical or something else, or because of toxic nature. Normally, in autoimmune disorder, what we are getting in Pemphigus group of disorder, what we are getting is primary acantholysis. We will take a acantholysis separate talk. We'll be having a separate talk on pulse therapy in dermatology. We'll be having a separate talk on corticosteroids. So don't worry, because everything we cannot cover today. In Pemphigus foliaceus, it is in the granular layer, or you can say subcorneal blistering is there, subcorneal cleft is there, or you can use the word acantholysis in the granular layer. DIF will show IgG and C3 deposit at the surface of epidermal keratinocyte ki surface, on the surface of keratinocyte. Okay, and IgA, if it is a IgA deposit with epithelial cell surface pattern addition to the IgG, may present in subset like IgA pemphigus. So you have to know epithelial cell surface deposit may be associated with a linear. If it is a linear granular deposit, IgG and C3, I told you. If intercellular, if this IgG and C3 depositing on the epidermal keratinocyte, plus it is depositing on the DEJ, dermoepidermal junction, along with C3. That is a lupus band test. Two things are happening. Dual. It is like a dual. It is suggestive of, it is like, pemphigus erythematosus. Okay. Even in pemphigus, your paraneoplastic pemphigus also you will be getting. You can get a lichenoid picture also. You can get even you can get in histopathology paraneoplastic pemphigus. You will be getting the features of normal pemphigus, plus you will be having even lichenoid infiltrate, band-like infiltrate. Even you can get vacuolar degeneration of the basal cell. So paraneoplastic pemphigus, as the lesions are polymorphic, histopathologically also you will get the picture depending upon what type of lesion you are getting biopsied. Okay, and you can have a multiple feature in one slide also. Serology, autoantibody deposition at the surface of epidermal keratinocyte, similar to the pattern seen in DIF. ELISA. So IF will show the same thing. Only thing is that you are not using the substrate is different. You are actually using the serum from the patient and you are putting in a substrate like monkey esophagus or guinea pig esophagus, depending upon the condition. So that you are showing, you are taking the serum from the patient, but the substrate is not the patient's skin, is something else. It become indirect immunofluorescence. ELISA, we are checking their, by the enzyme link immunosorbent assay, ELISA test, we are checking the titer, that is called ELISA. So you have to do DIF, you have to do IAF, and you have to do ELISA. Very, very important. And histopathology and clinical. So these are the 4 segments of your diagnosis. If they ask you what are the 4 segments of diagnosis, 4 bases of diagnosis, or 4 criteria to diagnose, these are the 4 criteria also. Okay. So when you are last part of the talk, they ask you why you are telling it's pemphigus vulgaris. So you have to. So in short, taken from JARD article, that first line of therapy nowadays is changing. Nowadays, along with steroid, we are thinking about rituximab. Earlier we had all, it was life-threatening condition. We never had anything. We did not have any much treatment for the pemphigus vulgaris. People were dying. Then we had steroids, and steroids started saving life. Now we have got rituximab, wonderful drug, because pemphigus is an autoimmune disease, B-cell mediated disease. Please check my immunology topic also, where I mentioned about B cell, what is the function of B cell, what is the function of antibodies. So this rituximab is basically chimeric CD20 and monoclonal antibody. It works on this B cell receptor. This basically B cell CD20 receptor. So it is anti CD20 monoclonal antibody, rituximab. Rituximab is a wonderful drug, very good drug. You can as a first line therapy. Okay, you can use in combination with the steroid. Sometimes it is used alone also. Okay, and the beauty is that you can use low doses of steroid. Like for example, you are treating a mild pemphigus. If it is there, or very mild pemphigus is there, so you can even steroid you can use 0.5 milligram per kg body weight. Then you can combine with the rituximab also. Okay, you can combine with the rituximab, or you can use as a monotherapy also. But when you are using with rituximab, you are having an option of using low dose of the steroid. And the beauty about rituximab is that when the patient you are given rituximab, you can taper the steroid very fast. Normally, how do we treat a patient of pemphigus? They will ask you how you are going to treat it. So normally we are having 2 phases. One is we consolidate that, first is the consolidation phase. Initial consolidation phase, that is called control phase. We are controlling the disease. We control the disease, okay, and then we maintain the therapy. Okay. So how do we consolidate? When we give the steroids, okay, and when there are no lesions for 2 weeks, and 80% of the lesions are healed, or there are no new lesions for 2 weeks, it is called as the disease is controlled. Then we start tapering the steroid. When you are using steroids with rituximab, you can do very fast tapering. In 3 to 4 months onwards, we can start tapering the steroid very fast. So over a 3 to 4 month period, we can do the tapering of steroid. So that is the beauty about putting it with rituximab. First line corticosteroid sparing agent, azathioprine and MMF. I already mentioned in my class of azathioprine and MMF. That's why I've taken this class just before pemphigus. So azathioprine and MMF are steroid sparing. With that, you can decrease the dose of steroid. And if it is, if it other steroid, cyclophosphamide, not good for the, all this gonads and all those problem with the hematuria. That's why little bit tough to use, but it's been used like even pulse therapy. And immunoabsorption and intravenous IVIG. IVIG, if the resistant cases, third line therapy, we are using IVIG. Sometimes they ask you what is plasmapheresis, and when nothing works, plasmapheresis can work. What they happen plasmapheresis? They take out the plasma. They separate the cells. They again put the plasma. They replace it with the normal plasma from other patient. Okay, So sometimes even you can if there can be depending thing, leukapheresis, where they do this thing with the white blood cell when they platelet, they can do it only with the platelet cell, or they can do it on the only WBC, or they can choose even the white cell component if they want to separate and put it fresh. In plasmapheresis, they put a fresh plasma, they take out it. Sometimes even they expose your WBCs to the pure therapy when it is it's called as photopheresis. They will take out the things and they will expose to the light, and they will again put it back to you. So there are various varieties of plasmapheresis, photopheresis. Please read it up, guys. Sometimes it is asked even when you are preparing for your entrance to when you want to become when you want to join some government services. In the viva they are asking about plasmapheresis. University exam, plasmapheresis is come up as a question. Okay, plasmapheresis is very, very important. And for you guys, when you are not able to treat patient, nothing is working, plasmapheresis is one of the good option, and you should mention in your exam also, like IVIG in resistant cases, your immunoadsorption another technique which is very, very important, and plasmapheresis. Okay, so anyway, you will not get a resistant patient so in the exam, but for future. So Pemphigus vulgaris DIF shows the deposition of IgG in the intercellular space, intercellular spaces between the epidermal keratinocyte. You can classically see the fishnet or chicken wire appearance. You can see the clefting here, and you can also see the rounding up and separation of keratinocytes from each other. So the separation of the keratinocyte and rounding up, obviously when the keratin intermediate filament, which is maintaining the shape of the cell, suddenly there is a clumping of the tonofilament, what will happen? The cell will become rounded up. Desmosomes are lost. So they have initially all cells were attached to another cell, so they were maintaining the shape as well as they were pulling the cells. When you remove the pull, what will happen? The cell will become rounded up. The classical look of a catholitic cell is that they are rounded up cells. Sometimes they ask you what is Zang cell. Zang cells, where Zang cell is having a hypertrophic nucleus. Okay, is having a morning edge. The basophilic edge is there. Nucleocytoplasmic ratio is increased. So that is a classical Zang cell. Okay, the rounded up cell where the nucleocytoplasmic ratio is increased. Okay, and this having a hypertrophic nucleus with loss of nucleoli is a Zang cell. So this is like a acantholytic cell here. You can see the lot of rounding up of the cell. Cells are lost, and there is a cleft. This cleft is suprabasal. Okay, it is not in the granular layer, it is suprabasal clefting is there. It is not that superficial. It is a Pemphigus vulgaris histopathology, classical. You will get one slide in the exam also for university. So the diagnosis of Pemphigus is 4 criteria. So they ask you what are the 4 criteria. When you say my diagnosis is this, so you can say this is the criteria of my diagnosis. So obviously you don't have DI. If you say I will do this and this and this to confirm my diagnosis, this will be your way. And always in the exam you have to say I will do this, I will do this, and that particular case you have to tell the treatment, not that I will. These are the treatment options. You have to say in this patient I will start because the body weight is this. I will start the patient on this much milligram of prednisolone. Like if you are telling 60 milligram, I'm going to start. So you should tell it is like it is like 1 milligram per kg if the weight is 6. So it is 1 milligram, or you are planning to start whatever dose you are going to start. You should tell like I will start in this patient this much dose, and I will tell you how much dose to start. I will be showing you flow chart, and depending upon the disease, you will be disease activity, you will decide your dose. Okay, but histopathology is must, biopsy is must, DIF is there, IAF, and so these are the things. First is the clinical history. You will be telling that initially oral mucosa was involved, 5 months later skin involved. These are the areas involved, and you did the Nikolsky, and the the Nikolsky sign was positive, and you will be doing a Esbo-Hansen sign. Esbo-Hansen sign. If there is you are getting a blister, which is an intact blister. If you the initial bulla spread sign was the Lutz sign. Lutz sign means this is a finger when you have put this is a blister. First of all, you will put a margin of the blister. This is very, very important. Put a margin of the blister with a pen, and when you put a margin of the when you mark the margin of the blister, either you can put the pressure on the center or you can put a pressure from the unidirectional pressure. So when you put the pressure on the center, okay, it is called as Esbo-Hansen sign. Sometimes they put it Esbo-Hansen sign as a Nichols type 2 Nikolsky or number 2 Nikolsky also they say, Nikolsky number 2 sign. So basically then they put the pressure on the blister like this, and bulla spread. How will you know bulla spreading? You have to see very clear closely. So if the margin, it will spread. If the bulla spread like this, if slight extension of the blister is like a rounded up extension is there, it tells you that it is a subepidermal bulla, means it is a bullous pemphigoid. If the margin, if the bulla is extended from the margin like a angular, there is a little angular margination is there. Little angular margination is extension is there. It is in Pemphigus vulgaris. So it is positive in both the conditions. Sometimes you get confused that whether it is positive. So as bulla Esbo-Hansen sign, also called as the modified bulla spread sign, which was initial was Lutz. The bulla spread initial was described by the Lutz, where they described by the unidirectional, when they are putting a pressure on the blister, and when because of the pressure, unidirectional pressure, the blister was extending, the cavity was extending to beyond the margin, and if it is so it was actually bulla spread sign. The modification is put in the center when the bulla is small. So these are the things you have to do. You have to do Esbo-Hansen sign, you have to do the Nikolsky sign, that is, and your history, clinical presentation, everything will be 1 point. So second will be histopathology, that you will tell I will be doing this point, DIF and this IF, and you can tell these are the findings I am expecting. And finally you have done everything. So my patient is confirmed patient of this and this condition. How much body surface area, you have to tell the body surface area. And you are doing a perilesional for DIF, you are doing the perilesional biopsy, okay, and serology. You know the Michel media. In the Michel media you can keep the DIF sample up to 2 weeks, because Michel media you have to read, the Michel media has got a buffer. It has got a buffer. Buffer has got a potassium citrate. Buffer is almost like 100 ml buffer is there. Out of that, yeah, they are putting 10, almost I think 80 ml is some water is there, distilled water is there. Rest of the other things are other parts are there. So Michel media, the content sometimes they can ask you can read it separately. This ammonium sulfate putting into putting in a buffer, and buffer, what are the contents of the methyl melamide or I think ethyl melamide, and this thing is there. This potassium citrate is there. So these are the 2-3 things in the buffer. So they magnesium sulfate. So magnesium sulfate and all these things is a Michel media. Sometimes they can ask you the content. I'm not sure at present what are the different content, but these are the content. And next is this you have to tell about the perilesional biopsy. So next thing is, so very important slide, histopathology. Preferentially a 3 to 5 millimeter punch biopsy of a recent. Make sure they will ask you what type of blister. It should be a fresh blister, less than 24 hours of a blister vesicle. Okay, it should be fresh blister. That means it has come in less than 24 hours. And 1/3 or you can take 1/3 of the peripheral portion of the blister. Okay, or 2/3 of the perilesional skin. Okay, you are putting this thing in a formaldehyde solution. Formaldehyde solution, or 4% formaldehyde solution you are putting. Should be taken for a routine histopathological picture. And epidermal, I told you, when there is a cleft formation, suprapleural cleft formation, acantholysis, dyscytotic keratinocyte, vacuolar changes, multiple changes, exocytosis, inflammatory cell, even sometimes you can get a lichenoid infiltrate band. That is the feature of PNP. So preferentially you should take 3 to 5 millimeter of punch. Should be fresh vesicle. Okay, or you can do a normal biopsy, like 1/3 of the peripheral portion of the blister or 2/3 of the perilesional skin. So you can take an intact blister also. So DIF, skin biopsy. How do you do DIF? From where you have to take? So skin biopsy of a perilesional skin you have to take, okay, or oral mucosa up to 1 centimeter from the recent lesion. Okay, so it is a perilesional skin. So they will ask you what will you take in DIF. You can say you are going to take a perilesional skin. You can send in a cryo tube, or you can send in a cryo tube is basically it is used for transportation in a cylinder of liquid nitrogen. Or you can just, if you are going, see, we used to send in a cold saline when we were in institute. If you don't have Michel media, you can use the saline. But it should be, if you are transporting the thing within 36 hours, then saline is okay. But if you want to keep it for 2 weeks, it is very far. You don't not be, then you have to use Michel media. Michel media is basically ammonium sulfate. Ammonium sulfate, what I remember, you please check guys, ammonium sulfate around 55 grams. To make Michel media, this ammonium sulfate of 55 gram is put into 100 ml of buffer. And 100 ml of buffer, basically 100 ml of buffer, 87.5 ml, around 87.5, 87.5 ml is the distilled water. And 2.5 ml is the potassium citrate in the buffer. And 5 ml is magnesium sulfate. And 5 ml is ethyl melamide. So 5 ml 5 ml ethyl melamide, 5 ml of magnesium sulfate, and 2.5 ml of potassium citrate with 87.5 ml of distilled water is actually total 100 ml is your buffer. In this ammonium sulfate is put. So this is completely a Michel media. Please check. I am not sure because there are some mole and some books are mentioning little bit variation of telling about Michel media. So the epithelial cell staining for in vivo IgG is normally granular or linear. EF examination and epithelial cell deposit sometimes can be associated with linear deposit. I told you linear deposit is there in the case of pemphigus erythematosus. So there are two pemphigus. One is paraneoplastic pemphigus, another is pemphigus erythematosus, where you can get dual fluorescence. Sometimes they use the word dual immunofluorescence. Dual means on the BMZ as well as intercellular. Okay, so in pemphigus erythematosus there is a, because lupus band test can be positive, no, that's why it can be linear, and plus pemphigus intercellular. And paraneoplastic again there can be a dual. Okay, so in specialized laboratory even plucked hairs are test for DIF. I told you the hairs are rich in desmoglein, so very important. Indirect immunofluorescence microscopy, IF examination of patients serum monkey esophagus. I told you monkey esophagus is very rich in desmoglein 3, or human skin to search for the autoantibodies, and the smooth and reticular staining pattern is also referred to as chicken wire or honeycomb. So these are the three names they use. Chicken wire, I already used this word, chicken wire, fishnet, honeycombing, like a honeycomb. No, have you seen honeycomb? So these are the three words they use. IF will tell you about the desmoglein 1 and desmoglein 3 on the cell surface. Okay. In case of atypical presentation, like when you are suspecting paraneoplastic pemphigus or there is a suspicion of autoimmune bullous disorder, additional immunopathological tests can be performed like IF microscopy or red bladder, because transitional cell epithelium positive in paraneoplastic. So red bladder they use when they are suspecting paraneoplastic pemphigus. ELISA is easy. I will be sharing in the WhatsApp group some reports also, some dummy reports of patients, how this ELISA test is reported. So they will be giving you a titer of desmoglein 1 and 3. Mainly 1 and 3 is done. So if they will be telling you whether it's a absent or it is like a it is very high amount is there. So mild, moderate, severe, like similar will be there. Like, okay. So normally there will be level like 0 to 14, 14 to 20, more than 20. Okay, depending upon which desmoglein we are talking about. Desmoglein 1 and desmoglein 3, they are having a different titer. In general, ELISA correlate with the extent and the activity of the disease. Okay, it is recommended to make the diagnosis of PVPF on the basis of the compatible with the clinical picture plus DIF finding and ELISA. If DIF examination is ready, it is recommended to repeat the biopsy for DIF microscope. You have to repeat. You are taking perilesional skin. Okay, you can put it in the saline, you can put it in the Michel media. Okay, or you can put it in a cryotube. Okay, you can cryotube. If new biopsy is not available or still negative, it is recommended to make the diagnosis of pemphigus in a patient with compatible clinical picture plus corresponding typical histopathological of acantholytic plus an IF on the monkey esophagus. In a particular case, the presence of typical histopathological feature acantholysis is absolutely necessary to exclude an erythema multiforme measure. So you have to do the Zank test also. That is a very simple bedside test. So you will be doing a Zank test in your patient, and because anyway ELISA and histopathology and the DIF you cannot do when the patient is given in university exam. Otherwise you will have to do it. You have to do it. So compatible with this picture, reactivity, all these things you can diagnose. So Zank test we can discuss as a separate when we'll be discussing one session on test in dermatology and test and sign in dermatology. We can discuss Zank test that time. So what is the workup? They will ask you what are you going to do. So if you are planning to start anyway, you are planning to start immunosuppressive. So you have to do the pre-steroidal workup. Anyway, blood pressure, height, weight, BMI, everything will be measured in the beginning itself. Complete blood count, very important to know any focus of infection activity. Well, not focus of infection, any infection is quite visible. In the normal hemogram will be telling about the anemia and other associated things also. So you'll get an overall picture about any there's a glucose, this level is any neutrophilia is there or not, the total leukocyte count is there or not, if the platelet count is normal or not. So anyway, this is very important, the complete blood count, creatinine, about the renal and blood electrolytes. So normally I do renal function test and liver function test, any transaminitis is there or not, including your gamma GT and your alkaline phosphatase, total serum protein, albumin, because these patients lose a lot of albumin. So when we will be discussing the treatment, don't just say I will start steroid. First thing in the treatment of pemphigus is you have to do the nursing. What type of nursing? You have to use the word in the exam, barrier nursing. So barrier nursing and nutritional support. Please remember these two N. nursing and nutrition. Nursing and nutrition. What nursing? Variant nursing. And then you will be going for electrolyte balance because they are losing exudate. There is a lot of exudate. They are losing a lot of serum. There are a lot of fluid. So you have to manage the electrolyte balance. So you have to order the electrolytes according to you have to manage the electrolyte imbalance. You have to do, you have to monitor the blood sugar because you are giving steroid. There may be up and down. Okay. So you have according to the patient. So you have to tell nursing, try to even keep the patient in ICU care. The patient is moderate to severe. Try to keep it away, isolation. Okay, and the room should be very clean. Everything should be clean. We used to use even banana leaves, or even there is a amniotic, the dressings are available. Proper covering of the lesions and the blend, moisturizer ointments are available to cover up the lesions. Very, very important. So that general barrier nursing is very, very important, that you are not going to touch the patient without gloves, and everything should be sterilized. The environment should be sterilized. So barrier nursing include everything. Okay. So that is the important. This is the blood test you will be doing, LFT, RFT, blood glucose, and anyway you will be doing the triple viral marker, hepatitis B, C, HIV, and the steroid also include the tuberculosis workup also, chest X-ray, PAVU, and all this thing meant to, and we am even doing quantifiable TB cold. So you will be doing the tuberculosis workup also. So at least you say chest X-ray and MEN2 and all this thing, the basic tuberculosis workup. And then see, and IgA is important when you are planning to do IVIG. So see, specific test, like if you are planning Dapsone, you will be doing G6PD level. Okay, G6PD level, bilirubin and reticulocyte when you are planning to do Dapsone. So reticulocyte, bilirubin, G6PD is for Dapsone. And serum IgA level you are doing when you are planning to start IVIG. And TPMT for azathioprine, we have studied in great detail. What is TPMT, thiopurine, methyltransferase, how much is the level, how much is azathioprine, we already discussed. Ocular examination very, very important because even there is a conjunctival mucosal involvement plus existing cataract or glaucoma, because all steroid can increase the chances of glaucoma, can exacerbate glaucoma. Chest X-ray in the PPD, MEN2 test is very important, 24 TB gold. Sonography, abdominal sonography, beta HCG when the pregnancy, for pregnancy. And you have to do, can do DEXA scan. We in institution and in exam also used to tell about the patient that we used to, because these patients are weak, weak, and there's a lot of nutritional problems. So this DEXA scan, because avascular necrosis femur can be because of steroids and all, there could be future problems in the bones. So you have to do checkup of bone. The DEXA scan is very, very important. That's called osteodensitometry prior to, because the patient is going to be on the chronic steroid. Okay, so okay, this is very, very important. So this is how we are planning to start the treatment. First is the mild. So patient is divided as mild Pemphigus vulgaris or moderate or severe. Moderate or severe is almost similar treatment because they fall into the same domain. So when the patient is mild, and we are talking about Pemphigus vulgaris, there will be a separate flowchart for Pemphigus foliaceus. I told you now the first line of trick is rituximab. Rituximab is coming, no conflict of interest. They are coming in the names, various name, Rituxan. There are a lot of companies available. There are even Reliance company has come up with very, very, very cheap, even 2000 something, per vial. Basically, there are two types of preparation available rituximab. One is the 500 milligram, another is the 1 gram preparation is also available. Basically, if you are having 500, if you are having 50 ml, 50 ml is having around 500 milligram, and 100 ml is having around 1 gram. So this, and you will be putting, when you are putting in normal saline. So what you do that out of 500 ml, you remove the 100 ml, because this 100 ml anemia is coming from the 100 ml is coming from the rituximab vial. Rituximab vial, I told you, coming in two types of variety. One is 50 ml, another is 100 ml. 50 ml is containing 500 milligram, 100 ml is containing 1 gram. Or normally we give 1 gram dose, so we need complete 100 ml. Either we have to put 2 vial, or we can use 1 vial of 100 ml. So it is a 500 ml normal saline, so we will remove the 100 ml of normal saline and we'll put that 100 ml from the rituximab vial and we'll mix it. And we will be giving, I will be telling you how was the dose. Okay, we are starting at very low dose, and normally you have understood like almost it is containing, like if it is like a 15 ml is 15 ml is containing how much? Almost 30 milligram. Okay, so because 500 ml is containing 1 gram, so 1 ml is containing almost 2 milligram, almost. So normally we start as a lower rate, we give the infusion over a 6 hour. I will be telling you the protocol. First, try to understand what is the guideline. So the latest guideline, European guidelines are mild pemphigus. You start with rituximab, 2 infusion. If the patient cannot afford, then please don't say. If a very poor patient, don't say. But this is a recommendation because when you are practicing in a tertiary care, this is the recommendation you are going to follow. So rituximab 2 infusion, you will be giving 1 gram. This is basically rheumatoid arthritis protocol. There are 2 protocol, lymphoma protocol, rheumatoid. Yeah, this is rheumatoid arthritis protocol. 1 gram injection you will be giving, and you will be giving 2 weeks apart. So 1 injection, after 2 weeks again you will be giving 1 injection. So normally these 2 injections are enough, and then you give this injection after 1 year, but you will not be giving 1 gram, then you will be giving 500 milligram, and then 6 monthly you have to give 500 milligram. This is what they follow, and you have to monitor the patient very closely. Okay, every once in a month, and initially even bi-monthly you have to use, bi-weekly you have to call the patient. Monitoring is very, very important. We will be seeing in the subsequent slide. So first line of therapy is rituximab, and we have got systemic steroid. Systemic steroid, when you are treating with a mild pemphigus, the lowest dose is 0.5 milligram per kg body weight to 1.1 milligram per kg body weight. Okay. Systemic steroid you can use with rituximab. Normally we are not combining this therapy, okay, because it is a mild. Either you give rituximab or you can give steroids. Systemic steroid you can give it with or without azathioprine and MMF. I already told you. Okay. If the disease control is achieved, continue previous treatment with rapid decrease in order to stop. Normally, I told you 3 to 4 months we are planning to stop the steroid therapy. Okay. But if the patient is with rituximab, we are treating the patient steroid with rituximab, we try to taper off 3 to 4 months. But normally, if the steroids are given monotherapy, I told you we are monotherapy, then we don't get that facility of tapering very fast. Then we have to taper slower when it is monotherapy. Second line therapy treatment, disease not getting control or we are getting side effect from the steroids or immunosuppressant. So initially the patient was treated with prednisolone, so we add rituximab. So same thing, 2 infusion of rituximab, 1 gram, 2 weeks apart, and then rapid decrease of the prednisolone. So the patient can, be tapered off the steroid very fast. Patient was initially treated with prednisolone plus rituximab, then increase the dose of the prednisolone. If already we have used the combination, so try to increase the prednisolone dose up to 1 milligram per kg per day. Okay, and then also not control, then we have to use some other alternatives. Okay. Now we are dealing with mild pemphigus foliaceus. See, mild pemphigus foliaceus is already very mild, and already mild pemphigus foliaceus. So sometimes here the treatment, the guideline is not steroid in the beginning. There is a steroid, but Dapsone is also given a priority. So you can use Dapsone 50 to 100 milligram per day. That is around 1.5 milligram per kg body weight, usually combined with the topical. So you can apply topical steroid, but the large areas are involved, and there is a problem because it can cause this HP axis suppression. Topical steroids alone can be used. Systemic corticosteroid when you are using low doses, or rituximab we are using 1 gram 2 weeks apart. So these are the first line therapies. First line therapy Dapsone, topical. So here topical steroid are also optional. Remember in pemphigus foliaceus, systemic corticosteroid and rituximab. Disease control is achieved. Then if it is yes, then continue the previous treatment, Dapsone or whatever you started, prednisolone or topical steroid. If it is not controlled, then you have to add rituximab. So rituximab is added whenever it is monotherapy is not working, or it was something else, then you have to add prednisolone, or if it was already prednisolone, then you have to add azathioprine, mycophenolate, and mopidol. Obviously, this is the way we are doing. No, we are adding steroid sparing agent when you are not getting results, because we don't want to increase the dose of steroid. We just want to have some sparing agent. Second line treatment rituximab alone or in with corticosteroid, systemic corticosteroid, prednisolone with or without azathioprine, MMF, or rituximab is not available. Okay, you can use if these are the second line therapy. So normally we are preferring Dapsone, topical corticosteroid. Okay. So when you combine with this second line therapy, means you are combining the steroid and rituximab. Okay. The patient is previously treated and not getting improvement. Moderate or severe. So moderate and severe, everything comes together, whether it is pemphigus vulgaris, pemphigus foliaceus, and we are not separating moderate pemphigus from severe. It is almost similar treatment depending upon the patient's condition. So first line therapy, as I mentioned nowadays, rituximab is the latest it is the main first line therapy, rituximab, 2 infusion of 1 gram, 2 weeks apart, associated with the systemic corticosteroid, prednisolone 1 milligram per kg body weight. So we have understood the dose is 1 milligram per kg. Here we cannot afford 0.5 milligram per kg body weight. At least 1 milligram. So if it is 60, so it is become 60, if it is 1 milligram per kg, so it will become almost 60 milligram of the prednisolone you have to give. Okay. Then with a progressive tapering, if the in order to stop corticosteroid after 6 months, at least plan to stop at least for after 6 months stop. Systemic corticosteroids, oral prednisolone 1 to 1.5 milligram. If you are not giving with rituximab, you have to use minimum 1.5 to 1.5 milligram per kg body weight. Or with, if you see, if you can use this when you are using, when you are using steroid, you can use even with azathioprine or other immunosuppressant. Normally, this is the scenario which happens normally. What happens? We don't have rituximab, the patient is poor. So we give a systemic steroid, we go for the 1 to 1.5 milligram per kg weight. And then finally we start adding this so that with the help of the other steroid splinter, we can start tapering. This is the normal thing. So if there is no disease, this is controlled at 3 to 4 weeks. So we have to increase the dose up to 1.5. So maximum dose is 1.5 milligram per kg body weight. Okay. Don't go more than 1.5. Or if you are, that's what I was telling. Even the patient is if he is requiring more than 100 milligram of prednisolone, so better to give pulse therapy. I normally don't prefer pulse therapy, but I have worked in a institute where pulse therapies are given. I have worked in a institute where pulse therapy not given. So there are two schools of thought. So little bit technically, I prefer not to give pulse therapy, but if the dose is exceeding more than 100 milligram, then better to go for a pulse therapy. What pulse therapy is? A suprapharmacological doses we are giving. Okay, in a pulses we are giving. So, and we are giving, see, pulse therapy, again, we are maintaining the conventional doses. We are maintaining even in between cyclophosphamide or steroid sparing, other thing. It can be DMP therapy, it can be DCP therapy, okay. But it's not completely safe. Okay, only thing is that if you are going too much dose, then prefer pulse, because pulse therapy is having it, claimed to be having less side effects. Okay. So initially treated with systemic prednisolone, increase the prednisolone dose to 1.5 milligram or add rituximab. So add or either you add rituximab or you add some other drug like azathioprine or MMF, depending upon how you treated the patient initially. If you have treated the patient initially with only steroid, you can add either rituximab or azathioprine or MMF. Okay. Or if you have already initially treated with prednisolone, you can add in the rituximab, or you can add any other immunosuppressive. Okay. So initially try to increase the dose. Okay, initially either you increase the dose after 3 to 4 weeks, 1 month anyway you have to wait. After 3 to 4 months you are not getting good response, then increase the dose up to 1.5 milligram per kg body weight. Or if you don't, or you can add some other, if the patient condition is very severe, then better to add other immunosuppressive, so you can taper the steroid. Okay, or for a better control. If the disease control at 3 to 4, continue the previous treatment. If it is controlled, then continue the previous treatment. Very, very common logic. If the disease is controlled with either rituximab, corticosteroid, or the combination of them, then they continue the same thing. And planning, if there is a complete relapse, okay, so rituximab is there, initially presented with severe pemphigus, still having a high rate of anti-desmoglein. This is very important. ELISA, you have to keep monitoring. So at the end of 3 months, still having anti-desmoglein 3 antibodies. Okay. So you have to add a maintenance treatment at 6 months. Maybe you can give 500 milligram, or sometime even they are repeating the complete cycle. I don't recommend it. Only few books or few literature available for repeating the cycle. Ideally, it is risky. Or you can give a maintenance dose of rituximab. Ideally, it should not be given below 12 months, before 12 months. Normally, you give at 12 months, and after that, every 6 months you are giving. Initial 2 doses you have given. After 12 months, you are giving, but you are giving only 500 milligram. But if it is not working, if there is high titer of the desmoglein, just like a relapse, it is very severe disease, you may have to give an additional dose of 500 milligram or 1 gram at 6 months. Rituximab 2 infusion in the patient is complete without complete okay, resolution is there. If there is no resolution, if there is the patient therapy, two infusion will be given in a patient at 6 months. We are talking. So that's what I'm telling. Very less literature is available to complete to give complete one cycle again. So maintenance, normally we give maintenance at 12 and 18 months. Rituximab 500 milligram at 12 months. We are giving. This is what we are doing. Rituximab when the patient disease is controlled. When the disease is controlled at 3 to 4 weeks. You have to give. Okay. So rituximab you have to give at 12 months. So normally when we start rituximab, this is the protocol. We give rituximab in the beginning at two doses we are giving 2 weeks apart, and then we give at 12 months, and then once in 6 months normally we do this way. So diagnosis of paraneoplastic pemphigus, there are various criteria for diagnosis of paraneoplastic pemphigus. So diagnosis of paraneoplastic pemphigus is not that difficult, but sometimes it can be a enigmatic for you all of you. So I told you there will be a polymorphic lesion, and there will be recalcitrant stomatitis. There can be lichenoid lesion or multiformic like lesions. So whenever you see polymorphic lesion in a patient, there are blisters, there are lichen planus like lichenoid lesions. So, and there is a recalcitrant stomatitis, very pathognomonic PNP, then you have to consider our PNP. So lesional histopathology show diskertosis, lichenoid interface, dermatitis, and histopathology in addition to acantholysis. So acantholysis is already happening, plus lichenoid infiltrate, macular changes in the basal layer, and you will be getting IgG, C3 and DEJ also, and you will be getting intercellular. There will be dual immunofluorescence will be there. IF, normally I told you in the case of paraneoplastic pemphigus, we use different substrate. We use red bladder. So we will put the patient serum on the red bladder. It will show cell surface staining or epithelial cell corresponding to the activity again the plaquin protein, because it is rich in plaquin protein. And we know paraneoplastic pemphigus, there are a lot of plaquin, periplaquin, envoplaquin, okay, epiplaquin, and plactin. So many things are there. So immunoblot, you can do even immunoblotting techniques with a epidermal extract show IgG against the envoplaquin 210 dalton and periplaquin 190 kilodalton, DSG3 130, and more rarely DSG1, which is 160. You know, DSG1 is also called as 160 kDa. Anti-desmoglein antibodies can occasionally be detected. This is how to detect these antibodies is by the immunoblotting technique. So now you can mention about immunoblotting also. And anti-desmoglein antibodies are occasionally seen, usually associated with the anti-envoplaquin antibodies. Alpha-2 macroglobulin like 1, A2ML, can only be detected under non-denaturing condition, non-reducing condition. Okay. Immunoblot with extract from cultured keratinocyte reveal IgG against the envoplaquin, periplaquin, desmoplaquin. So don't worry, it's very easy. All the plaquin, envoplaquin, periplaquin, plactin. Okay, so this is very easy. Don't worry. And it's like a khichdi means mixture of so many findings. So it's like a khichdi, because tumor antigens are in plenty. Tumor can produce many antigens which can mimic many of the parts of our skin structure. Okay. So immunoprecipitation with keratinocyte extract is not performed in clinical. Can reveal IgG autoantibodies again, envoplaquin, periplaquin, desmoglein, all these things. So there envoplaquin is actually commercially available test. Okay, envoplaquin is available. You can do the titer. So this is the normal tapering schedule when you are treating a patient with pemphigus. Even what I do is that I start tapering by 10 to 25%, depending. If 10% means if it is a tapering, if it is a very severe, I won't go for 25% tapering. If I can go for 25% dose tapering every 3 to 4 weeks, or normally initially I taper like 10% dose every 2 weeks. Okay, until I reach 15 to 25 milligram, depending upon the patient. Always is the scenario, patient scenario is very important. Then I start reducing by maybe 1.25 milligram. Normally you can break, like 5 milligram is 2.5 again broken to 1.25. So I go very slow tapering. Once the patient reach 15 milligram, I go with very slow tapering. In some patient, even I start slow tapering after 25 milligram. I'm telling about my patient, my experience. Because after 15 to 25, it is a very, sometimes there can be relapse. So when the patient is having dual therapy like rituximab steroid, I will be tapering my steroid very fast. Over 3 to 4 months, I will start to a good amount of tapering of steroid. When the patient is on monotherapy and patient, like at least I will keep the patient for 6 months on the steroid. 6 months is a very important time. After 6 months, what to do is nobody's is always depending on the patient. Normally we do ACTH test. We should have, at least maintenance basic physiological 5 milligram dose for a long time. You need to do lot of, you need to give them a lot of other things like vitamin D, okay, various, you have to give electronic, whatever, endocrinological, you have to support the bones also. So you have to take an endocrinological opinion, you have to take a physician opinion, okay, bisphonates you are giving, no, for the bones and all. Important thing is that how is the tapering is depending upon the patient. Normally, what the tip from my side is that when you reach a 15 to 25 milligram, in between you are like near 20 milligram or near 15 milligram. So after that, tapering should be very, very like 1 milligram per kg, 1 milligram, per kg body weight. You are by that like 1 milligram, 1 milligram, not 1 milligram per kg, 1 milligram dose, not per kg, 1 milligram, 1 milligram. You cannot do by 1 milligram. You will be doing by 1.25 milligram tapering. You have to start after, until it reach 5 milligram, and after 5 milligram, what to do is a tough thing. Normally we have to maintain for the 5 milligram for the long time. Normally 6 months is the time over which we taper it. We start tapering once. I told you the disease first is the consolidated phase, second is maintenance phase. Consolidated phase means when you are giving a fixed stable dose and that dose has reached a particular dose, you are see after 3 to 4 months, if you don't get the response, you start increasing the dose by 0.5 milligram per kg body weight, and you go up to, you can go up to 1.5 or 2 in the max. So normally 1.5 is the cutoff, and if you are if you maintain that dose, and if you are for 2 weeks, if no new lesions are coming and 80% of the lesions are improved, that means your initial control phase or consolidation phase is over. 80% of the lesions are resolved, no new lesions are coming, start tapering. Okay, so tapering can be like a 10% to 25% of the dose, from over 2 weeks to 3 weeks, you can start tapering. Every 2 weeks or every 3 weeks you can start tapering, or you can taper by a simple thing, by like a 5 milligram every 2 weeks you are tapering. Or okay, and but when you reach the dose of 25 milligram and your patient was very unstable, okay, so try to do the tapering, very slow tapering, maybe like 2.5 milligram tapering every 2 weeks when you have reached 25, and when you reach 15 milligram, then go for 1.25 milligram per 1.25 milligram per day. Not is a not it is not per kg dose, it's just like 15, you are going for 13 point some 7 point like that, because 5 milligram is available. You break the tablet, it become 2.5, you break again 1.25. So below 1.25 milligram tapering you cannot do. I think it's very tough to give the dosing schedule also. So go up to the 5 milligram. So every 2 weeks you start tapering. Every 2 weeks is the tapering thing. Okay. So normally this is very complex. So you can follow this dictum. This is given by the European guidelines. So this is easy. Like this is like a universal thing. So like first 1 month you give this much dose, 0.5 milligram. If you are giving this, so you make it 0.5 to 0. This is a tapering schedule. So second month you give 0.3 milligram per kg. Third month you give 0.2 milligram per kg. Very easy. And fourth month 0.1 milligram per kg. This is for the moderate or severe. And for the patient, like this was for the mild. This is shifted. Sorry, this is slightly shifted here. This box is shifted. So this is for the mild. Obviously, moderate and severe will come here. Moderate and severe is this one box on the top is shifted. Sorry for that. So mild pemphigus 0.5, 0.3, 0.2, 0.1. I already told this is the way. For moderate and severe will come here. So we know moderate and severe we are giving minimum 1 milligram per kg body weight. If the patient is 70, we will be will be giving 70 milligram, 60. So it is depending upon the per milligram per kg body weight. So go for this dose, and second month you give 0.75 milligram per kg, then you give 0.5 milligram per kg, then you 0.3 milligram, 0.2 and 0.2. So normally mild pemphigus we give steroid around 4 months. Moderate and severe pemphigus we give steroid for almost 6 months, and then we start tapering. Okay. Sometime after 6 months we completely stop when we reach 5 milligram for a long time, and then but normally what I give is I extend for a little bit more months, at least maintain for 5 milligram for many months, or take an endocrinological opinion or ACTS test you have to do. This is the way. So remember this slide, this upper box is shifted. This mild pemphigus is here, moderate is here. Okay. So this is the regarding rituximab. To
one gram injections are given, 1000 milligram intravenous 2 weeks apart. Lower dose may be used. Some patient we can use only low dose like 500 milligram at. So this is lower dose. Sorry, lower dose. I already told about this, that when you reach 12, after 12 months, you will be giving 500 milligram. That is a low dose, and then you will be giving every 6 months. Okay. See, before giving rituximab, it is very important. Either you give hydrocortisone or you give methylprednisolone injection, IV, and you can give one paracetamol also. Paracetamol, we give paracetamol. We give this pheniramine maleate injection that is coming in the brand name, no conflict of interest. Pheniramine Avil injection we are giving. Avil injection is it is coming. So 1 cc, 1 ml, 1 ml, 1 ml, you can give 22.75, I think, no? 22.75 milligram per ml is there. So we give IV injection of Avil, and we give paracetamol orally, and we give either hydrocortisone or methylprednisolone. I prefer hydrocortisone. And then I give the injection for period of 6 hours. You have to do dosing. Initially, you are giving very low dose. Okay, very low dose for the 30 milligram. 30 milligram you will be every 30 every half an hour you will be increasing the infusion rate. So better to give it the infusion pump. Normally you should never increase the dose 400 milligram per hour, because every half an hour you are increasing the dose. Okay, so every half an hour you are increasing the dose. You can start like so you are not you cannot give complete infusion very fast. It will be a big polyp. If sometimes there can be infusion related condition, so you have to keep asking any abdominal pain, any fever, chills. You have to decrease your infusion rate also. Pre-treatment you have to do this test: triple viral marker and chest X-ray, ECG, cardiological examination, interferon gamma, okay, quantiferon gamma, and complete blood test. Okay. Contraindication: any active severe infection, never give it. Even heart failure, severe heart failure, never give it. Uncontrolled cardiac disease. Main problem is cardiac. So don't give any patient with cardiomyopathy or ischemic heart disease or uncontrolled cardiac problem. Severe arrhythmias if there is a history contraindicated. Basically, rituximab is contraindicated in cardiac patient. Okay. So and and always remember, you have to give a pre-rituximab. Pre-medication is very important. Infusion related condition. There are a lot of cardiac side effects, and leukoencephalopathy. It can cause depression, infection, mainly infections. Okay. And you have to now this is the this slide we have already seen. Actually, this is as a summary. We have already seen the JAD. Next is this also we have seen, that treatment, first line corticosteroid and rituximab. Rituximab, see, you have to remember one important thing about rituximab. If you are having allergy to rituximab or murine, any murine protein, never give rituximab. Normally, if CD4 count less than 250 is there in HIV patient, never give it. So pregnancy lactation also there is a problem. And rituximab, when you are giving, make sure you give pre-rituximab medication. And rituximab injection should be very slow infusion. It is when you are giving the infusion of rituximab, it is over 5 to 6 hours. So when we start the rituximab, you start at 50 milligram per hour rate. After 30 minutes, you will increase the dose 50 milligram per hour by another 50 milligram per hour. So it will become, instead of 50 milligram per hour, it will become 100 milligram per hour after 30 minutes. So we start with 50 milligram per hour. You can follow your institution profile also. This is what is universally followed. The protocols may be different for me. Still, it reaches the 400 milligram per hour. Never increase the dose more than 400 milligram per hour. So every 30 minutes, you are increasing the infusion rate. Initially, start with 50 milligram per hour until it reaches 400 milligram per hour, and you have to give the complete infusion over 6 hours. And the important thing is that maybe second time when you are giving rituximab, the second injection, you can start with 100 milligram per hour rate. But try what I follow it, I give the same rate. Okay, so these are the first line therapy, first line sparing drug and other corticosteroid sparing. This we already covered, same thing, revision from other journal. So these are all taken from big journals. Paraneoplastic pemphigus, there'll be bullous pemphigoid like lesions can be there. There can be pemphigus like lesion, GVSD like lesions can be there, lichen planus like lesions. So they can have polymorphic lesions. So please remember, these tumor antibodies, they basically tumor releases a lot of antigens. Okay, and very important. And so various antigen will mimic various structure of the skin. Sometimes they will mimic periplakin and moplakin, which were required for even cornified envelope. even Desmoglein, bullous pemphigoid antigen, which were required for hemidesmosome in the DEJ. So various picture can be there because hemidesmosomal bullous pemphigoid like antigens are involved. That's why bullous pemphigoid like picture will be there. Pemphigus like, so there can be what you get in bullous pemphigoid, even can you get urticarial lesions. So similar urticarial papules and plaques can be there, and tense fascicle can be there, bullae can be there, pemphigus can be there, EMF can be there. So very, very important. GVSD like picture can be there, disseminated rusky red papules, and lichen planus like lesions can be there. And there's a recalcitrant, and can be involvement of even esophagus, stomach, duodenum, intestine. There can be very, even lungs, bronchiolitis obliterans has been mentioned. Bronchiolitis obliterans, very, very, very dangerous condition in PNP, lungs involvement. So this was the initial criteria was Anhalt criteria, who initially described paraneoplastic pemphigus. Then came the Camisa and Help, which was followed for many years. Till now it's followed Camisa and Help, which say there is a major criteria, there are three major criteria, and there are three minor criteria. Either you should have all the three major criteria, or you should have two major and two minor. Either you have all the three, or you should have two major or two minor criteria. What are the three major criteria? I told you: polymorphous, mucocutaneous eruption, polymorphous. Second, characteristic immunoprecipitation, saying all the type of your various antibodies, antigen. So various antibodies will be there, and then you should prove there is a concurrent internal neoplasia. You are doing all the CT scan and everything. Minor criteria, you are seeing that acantholysis, at least in one sample, in biopsy sample from at least one site of involvement, you are getting acantholysis. So acantholysis is minor criteria. Intercellular and basement membrane zone immunoreactant. I told you it is a dual immunofluorescence. We are getting dual immunofluorescence, is minor criteria. Or this is, so in this Camisa criteria, the three minor criteria is acantholysis, second is DIF, and third was IF on the rat, on the rat bladder epithelium. So rat bladder epithelium, IF positivity, DIF is showing dual immunofluorescence, intercellular as well as on the BMZ, and your acantholysis. So that is your Camisa and Help. This current slide is showing you Swoboda Huang criteria. Actually, it's called as Swoboda et al. Criteria. I don't know what is the correct pronunciation, but Swoboda is a criteria which actually he studied so many patients, and finally he changed this Camisa and Helm criteria of PNP, and now he has added this mucous membrane lesion with or without cutaneous involvement. So this was one major criteria. Second is accompanying internal neoplasm, which was there in Camisa also, the previous slide. Then evidence of antiplaquin antibody by ELISA, indirect immunofluorescence or transitional epithelium, immunoblood, and immunoprecipitation. So that he put it into your major criteria. Everything, indirect immunofluorescence also went into your major criteria. Minor criteria, acantholysis is there as it is there in it was there in Camisa with lichenoid interface dermatitis. Intercellular or basement membrane staining, the dual immunofluorescence is still there, acantholysis is still there. So he has put only this criteria. So he is not having three, he is having only two minor, and he has included three major. So there initially the Camisa was having three major criteria and three minor criteria. Okay, so this is having three major but only two minor criteria, and they said that if all the three major criteria are met, it is PNP. Or you can have two major criteria and both the minor. If you miss one major criteria, means out of three you are having only two, then both the two minor criteria are mandatory. So they say it is having better sensitivity, like the Camisa Helm was having 71%, it is having 89% sensitivity. Okay. So immunopathology plays an important role in diagnosis of PNP. In indirect immunofluorescence, you will be saying intercellular deposition IgG and C3 are certain. Unlike Pemphigus vulgaris, linear C3 complement will be there, linear complement will be there, and to an extent IgG can be observed at dermoepidermal junction. This is like attributed to the binding of BP180 and BP230. You know that it is also involving the hemidesmosome antigen also. In fact, IAF and ELISA testing both found to be 40% of the patient have circulating autoantibodies to BP180. More likely to have a rash, tense bullae. Obviously, depending upon their immunoprecipitation. Immunoprecipitation will tell you which all antibodies are there, like periplakin, envoplakin, or BP180. So depending upon which are more, depending upon the clinical picture will be more. IF shows the IgG antibody to the stratified epithelium in the esophagus, other tissues of monkeys also. In sharp contrast to Pemphigus vulgaris and foliaceus, they also point with the transitional and cylindrical epithelium of urinary bladder, okay, intestine and colon, as well as to the layer extremity, the myocardium, skeletal muscle, and thyroid epithelium also. Main thing is this. Okay. Highest sensitivity 75% sensitivity are exposed to red bladder. So they ask in MCQ, they ask in quiz, what will you use? You will be using red bladder. You will be using red bladder because transitional epithelium is rich in plaquettes. Immunoprecipitation and immunoblotting, because these are the two techniques which tells you about all the various type of antibodies present. So immunoprecipitation and immunoblotting will only demonstrate desmoglein 3, 1, envoplakin, plactin, periplakin, desmoglein. So these are the thing. So there is a novel ELISA also. They are checking this thing. ELISA show the PNP serum react with desmoglein 1 and 3. Very special. Fluorescence on the bladder epithelium, that is a red bladder binding with protein. ELISA may show autoantibody. This is just a repetition. And I told you there is a commercially available ELISA for envoplakin is available, so you can do it. So this you can also do immunoprecipitation and mass spectrometry. So this is the occurrence. Normally, non-Hodgkin lymphoma is on the top list, 39% occurrence in the PNP. CLL 18%. It is the chronic lymphocytic leukemia. Then Castleman disease, which is mainly seen in mediastinum, or there's a lymphoid tissue in the mediastinum. There's a growth of that. Carcinoma, various other carcinoma 9%. Thymoma 6%. Sarcoma 6%. Waldenstone macroglobulinemia 1%. Hodgkin lymphoma, monoclonal gammopathy less than 1%. Remember, and normal pemphigus vulgaris also you can have thymoma. Normal pemphigus vulgaris, even your history when you are taking, there should not be any history suggestive of, because rheumatoid arthritis, your Sjogren's syndrome, rheumatoid arthritis, polymyositis, your your thymoma can be associated with your pemphigus vulgaris. Sometimes they ask you what are the associations of pemphigus vulgaris. So remember, myasthenia gravis, pernicious anemia, polymyositis, Sjogren's syndrome. Okay, you can have rheumatoid arthritis. You can have the thymoma associated with the normal pemphigus vulgaris also. So please remember myasthenia gravis and all. Okay, sometimes that can be a question. So pemphigus vegetant we have already covered. This is almost 1 to 2%. We will be having verrucous plaques. Sometimes it can even form on the angle of the mouth or the lips. Newman variety is severe variety. Halopio variety is a benign variety. Newman variety, it mimics like a pemphigus vulgaris with vesicle and blisters rupture to form hypertrophic lesions. Exudative vegetating masses, and very, very severe variety of Newman variety. Halopion is a mild variety, begins with the pustules and rupture is a only vegetating erosion. So they ask you what is the severe variety, is the Newman variety. Halopia is a less severe variety. It is, they can have a, this is having a lot of granulation tissue, all these things, a lot of secondary infection, fetid smell can be there. Oral involvement can be there. I told you the Premlata sign, the cerebriform tongue, the respected, our respected madam. She has given a lot of signs. Neonatal pemphigus, because of the passive transfer of the antibodies to the fetus through the placenta. You know that it can have vesicle, blister, erosion. So the presence in the neonate. So it is because of the mother is having those antibodies, and it is found in 30 to 45% of the patient with pemphigus vulgaris. Sometimes they ask you how much percent, 30 to 45%, because of the passive transfer. So it is transient, we know, and within 3 weeks it will disappear. So finally it will be improved. Now the new drugs which are coming, because this is because your rituximab is a chimeric monoclonal antibody. So now we have got ofatumumab. Ofatumumab is a humanized, same anti-CD20, because it is working on the cell receptors of the, because all these drugs, what are they causing? They are causing B cell depletion. So rituximab causes B cell depletion. So we have got another in the list called ofatumumab. So they can ask you what is ofatumumab. Ofatumumab also works on CD20. It is fully human. Then we have got veltuzumab. Veltuzumab is a second generation humanized. It is again humanized. It is, so we have got ofatumumab and veltuzumab. These are the new. And belimumab, which is used in your cell, which is basically, I told in the B lymphocyte stimulator in my immunology class. It is a B-list. B-list is a soluble B lymphocyte stimulator. It is a stimulator of B lymphocyte. So there is an antibody against that also. That is called monoclonal human IgG1 antibody, which is coming in the name of belimumab. Belimumab is a wonderful drug for your SLE. So it is again tried for your pemphigus group of disorder also. So these are the new drugs which have come up. Okay, even they are there are new drugs which are targeting your acetylcholine receptors. Okay, and beside these, all these immunosuppressive, we are using doxycycline, tetracycline. Tetracycline is are used in treatment of almost every patient. We try to put on tetracycline up to 2 gram per day, 500 milligram TDS of 4 times, 6 over D. total 2 gram we can give of tetracycline, even niacinamide, nicotinamide they are giving. And so there are a lot of other things also. So this is the end. So we can see the drugs in dermatology. We are already seeing it. So separate drug will be we'll be seeing. Okay. So this is, I was telling about plasmapheresis. Very wonderful result. Nothing but the plasmapheresis work. Plasmapheresis works very well. This is wonderful therapy, plasmapheresis. You can see the response after plasmapheresis. Okay. And when I was telling about nicotinamide, normally nicotinamide and tetracycline combinations are better, in the case of bullous pemphigoid and pemphigoid group of disorder. But it still work in pemphigus because nicotinamide can inhibit even interleukin 1, interleukin 6, various interleukin also. It has got a very anti-inflammatory role, nicotinamide. Up to 1.5 gram, 1.5 gram you can give per day. 1.5 gram per day. Tetracycline also you can give combination tetracycline, but normally that combination is used in bullous pemphigoid. Oral care in pemphigus vulgaris is very, very important. Even hydrogen peroxide, diluted solution spits are done. Main thing is always do the herpes serology. Try to cover up with acyclovir, with regular creatinine and the renal monitoring, and dose should be titrated of the acyclovir. Nutritional support is very, very important. Oral care, the candida is very, very common commensal which overgrow. So candidiasis you have to treat depending upon the patient body weight. Sometimes we give 100 milligram daily for 1 to 2 weeks, even with the stat dose of 200 milligram of fluconazole. So depending upon the severity, you have to treat the oral candidiasis with the oral candid mouth pain 4 times or 3 times a day. The swish and spits are done normally after when you have consumed the food. The oral hygiene has to be maintained, dental hygiene has to be maintained. You have to use with a baby brush or very finger, because even can be active Nikolsky, because of that it can lead to even erosion. So even you can elicit a erosion Nikolsky by the earbud in the oral cavity. So these are some modification in oral cavity. The oral care is very, very important. Whatever I taught you is for the university exam, for learning. The treatment is decided according to the patient, according to the old workup. It's not same for every patient. You have to spend time with the patient. You have to judge the patient. Every patient is not same. Remember, pemphigus is a tough. If you are in hurry, you cannot treat every patient with the same dose. You have to see whether the patient is what is the total overall the overall understanding of the patient is very, very important about the quality of life. So the dosing schedule has to be dependent upon that. Okay. Even sometime like there are a lot of other secondary infections, so you have to see whether what is your priority first of all. Okay. And oral care is very, very important. So, and whatever treatment option I told you, you have to see according to the patient, according to their experience. You cannot fit the same thing. And so treatment according to your institution guidelines, treatment according to the patient. Okay. So this was only overview and some of my experiences I shared. And these are my references, besides various textbooks, these are my various journals, articles, lot of journals, articles I studied to prepare this talk. From this article. So here I stop. Thank you guys. God bless you. And one thing, even remember, normally is a B cell disease, even T cells. There is a T cell theory, that T cell activation, because autoreactive T cells are produced against the Desmoglein 3 and all. So because of autoreactivity, the loss of regulation, because why there is a loss of self tolerance, because almost all the autoimmune disease there is a loss of self tolerance. So even that point is there. So there are various theories about the acantholysis. We will pemphigus. We will be seeing why what is happening. There is a cell shrinkage. We already discussed about apoptolysis. We have discussed about the P38 MAPK pathway. And multiple hit theory means multiple antigens, autoantibodies are there. Multiple hit, it is there. Multiple targets are there, and we have a autoreactive T cell because there is a loss of regulatory cells, and autoreactive T cells are acting against the own desmogleins. So and finally it's a B cell mediated disease, but there is a role of T cell, and there is a TS2, more of like a TS2 type of interleukin profile. 4, 5, 10 type of interleukins are there in pemphigus. So this is enough. I think you can study more, whatever other books you want to see, you can see. Thank you so much.